socket grafting girl. Okay. And we will talk about all the different steps. There's going to be some minor like things that will jump in here. I have someone who's going to talk with you about different types of implants. Because it's not, and we will talk about all, oh, is that my oh my goodness. I will have different types of people who will come in on tomorrow. I feel like there's somebody else. Also, of course, we're going to have you actually place the implants. So that you will be instructed by a periodontist. I'll tell you this, oral surgeons and periodontists don't mix. It's like oil and water. We are not friends because they are very particular folks with their little measuring tools. I'm like, you know where you can stick that tool? But those folks are precious. We have to love them. And I found one that I actually get along with. Dr. Honorable introduced him to me. His name is Dr. Gan Filippo. He's originally from Italy. And so he has his Italian accent. And there's going to be some minor from Seattle, Washington. So the time is a little off. It might be, 4 in the morning for him and 7 o'clock in the afternoon, in the morning for us. So we have him going. He will be diligent to talk with you about how do you place implant from tooth, the space that's necessary from tooth to implant, and also implant to implant. And he will be meticulous with his measurements, so be sure you take the notes. And he also has corresponding articles that are in and provided to you in this book. I take a lot of time to print these. I'm a hard copy girl. I do not type a bunch of stuff. I might not really very good with computer, but if I can print it and get a highlighter, I will memorize all these things. Somehow it works. So I thought, well, if that works for me, let me find a way to teach the students utilizing hard copies. So each one, sometimes the librarian, I go to the library to do the copies. The librarian is like, okay, this is 15 pages for this one and 12 pages for that one. And then I sit down and I put them all together for all the students. And also, there will be a point where we might go, well, for sure, we're going to go for, we have so that's Tuesday. Wednesday, I'll call it our field trip day. It's like I get all the kids, we get on the bus, we go for a trip. I want you to bring your binders, okay, on Wednesday. Wednesday is to expose you to cutting edge technology. So at that point, you should have understood how to restore, understood how to properly analyze and evaluate patient, understood options for socket grafting, understood how to place them. Now I want to totally blow your mind because you may be accustomed to taking impressions, sending it to the lab and having the lab produce some kind of crown. This is 2025, folks. That's old news. So what you should be exposed to is intraoral scanning, extraoral scanning, and how you can mill the crown in your own office. So we will literally get in the shuttle, or it could be my car, I'm not sure just yet, and we are going to the YM Dental Lab. We will do a tour. Sometimes I tell the students, we're going to a lab, and they're like, oh, lab, why would you do that? It sounds so stupid, and what a boring activity. Wait till you see the lab. Okay. I don't talk about it if I can't be about it. And this lab will open your eyes to new elements, okay? In addition, on Wednesday, we will come back after the lab because we need to hustle and get back here. We will do the hands-on. Each lesson has a hands-on model. We may push the hands-on for socket grafting to Wednesday. And then, because the students have come from so far, from all across the world, quite frankly, we've had students from Nigeria, we've had students from Kenya, we have students from Ghana, we have students from New York, Maryland, DC, Virginia, and California, we go to Washington, DC. So that is planned and scheduled for the afternoon of Wednesday. I've had a group say, I don't want to go to DC. It's part of the, it's part of the curriculum. Mm-hmm. If you are strong-willed and say, I'm not going to see the Washington Monument, then let me know. But that's what's expected. Once we get to the Washington Monument, we walk around, we see the Capitol, we have lunch with the food trucks, trying to hang out. And then that's to be expected for Wednesday. Finally, Thursday runs up. Thursday is going to be your CPR class. I hope everyone has registered. I believe everyone has. Did you get around to it?
What did it look like? I don't know if I saw the
okay.
link to it.
Okay. Can I touch your computer? Just for a second.
No, there's a Zoom going on there.
Okay.
Okay, send it to you. Is everybody on the chat?
I'll send it to you again.
So-
No
Yeah.
problem. You have until Thursday. What
Okay.
has to happen, and hopefully Isaac and Dr. Plotkin have done this, is there is a pre-course that you
Okay.
have to take.
Okay.
The whole room will be changed over again. I'll
Okay.
swing the tables up. We're gonna get you mannequins. You're gonna do CPR. Okay. That is also my slight admin day because I have to send all the stuff back. So I will put you in the hands of a responsible adult, and then I'll take care of stuff and I'll come back with lunch. And then that's pretty much all day Thursday. Last but not least, Friday is designated for observation. So if we didn't jump in and out, then we will be jumping in and out for sure on Friday. And Dr. Bati usually leaves around 1 because I think you're trying to hang out with friends on Friday. Is that still happening?
Oh no, I'm leaving Friday.
You're leaving Friday. Okay, when do you hang out with friends? Every Wednesday?
Yeah.
Okay, in DC?
Yeah, so I have to figure that out.
Working on that.
Yeah,
Okay, come
but
back.
if it has to, right, adjustments, yeah.
So that's Friday. That was a quick housekeeping of what to expect for the week. I will not hold Dr. Honorable up any longer. I'm sure he's like, she needs to let me start. And there's some minor adjustments to the schedule that you will learn how to do a suture workshop. You will learn how to place IVs. We feel like that's very important. As general dentists, you should know how to place an IV. Do you know how to place IV today? You do already? Okay, how about you? Oh, good. So then we will make sure you know how to before this is over. And eventually I'll give everybody a document to give us evaluations. And then also everyone gets certificate of completion. Does that make sense? Any questions for me? Okay, then without further ado, Dr. Honorable. Oh, yes. And I'm also not only gonna make you money, but I also think about your stomachs. So there will be multiple points when I'm like, are you hungry? We have food. Let's make sure we eat the food. Okay, so that the breakfast will be served shortly. And I haven't told you this, but there's a bathroom. This is the bathroom if you need.
All right,
Okay, very good.
Thank you.
Let me find out. We're ready for you, Doctor.
Okay, good. Anyways, it's good to meet everyone. This is a close-knit class. So it's a no judgment zone. You can ask any question, and the intention is that you will get a little more familiar with. You have the armamentarium with you here. In front of you, you have a kit. You can open it. Just take a look at it and just get familiar. This is the tool of the trade because that's what you need to have. So we've been given these by BioRising. We also have an opportunity to buy some of these products. Because once you finish doing it, it's like I keep saying, it's easier than pulling teeth. If you can pull teeth, you're fine. This is a lot easier than pulling teeth. And so we're going to try to get familiar with all these parts. One thing I've said, continue to say, every time you take a tool out of this, put it back where you took it from. Especially, that's what you're going to tell your assistant. Make sure it goes back. They need that instruction so that things don't get mixed up. But this is exactly what you need. You need a model, you need a handpiece, and you need the drills. You are trying to make an osteotomy, a hole in the bone, and you're trying to replace aesthetics, function, and some kind of form. So this photograph here just tells you, we say it's prosthetically driven. So the patient comes to you, they're not coming for implants. Nobody comes to you and said, well, they might say I want implants, but what they're trying to say is I want teeth. I want to be able to smile. I want to be able to eat without shame. People tell me my dentures, I take them out when I'm eating and it's so embarrassing. People want aesthetics. People want to be able to function. People want some social acceptance because going out without teeth doesn't really make you accepted. So that's when they come to you and you're trying to say, okay, this guy, this gentleman who came to me came saying, I'm a trumpet player and my long stand bridge is failing. What can you help me to do? And I have a couple months and I'm going somewhere. Can you give me something? So if you don't have implants as part of what you offer, you're going to offer different things, right? As dentists, we can, what to do. We can offer him something and just get him to go. But if you want something that he doesn't have to take out and the cost. So if they have money and they have bone, come on, let's get, most I work for Clear Choice. They know those who have good insurance or good credit. They don't care if you don't have money. They're like, okay, if you have good credit, we can get you some teeth. But that always comes out of discussion. There's a little lag here, but just bear with me.
How do you get that square off? Is it here?
See. Let me see if I can use.
And also, if I push the Zoom, how can I connect?
So yeah, so the Zoom, this is the Zoom right now.
Mhm.
Yeah, so we can restart it.
Okay, is it recording?
It's not it's recording is on YouTube. So anybody can actually see this, anybody who is on YouTube, but we didn't advertise this, so nobody knows, but you'd be surprised somebody's on there from Pakistan.
Send me the recording.
Sure, I'll send you a
Do you
recording.
need this to take the rectangle off?
Let me see.
Did I bump it? Like sometimes I bump the remote at home and then it makes the grid come up. No?
No, I'll figure it out. Anyway, this is me. I do a lot of traveling around the world. We go to different countries. I've been to Ghana and to do dentistry. So I do Healing Hands Health Society. We take doctors, we take teams, and we're trying to get Dr. Jackson to come with us to Kumasi, Ghana. Hopefully that takes place soon. Yeah, so this is where we all get connected on Instagram. So if you have Instagram, let's get together. Some of the videos, we make videos like the video we just made outside. It's going to be on Instagram. People get connected to it. And you can reach us email, with Dr. Jackson. You can reach out on the phone. If you have an issue, you have a case, you have something, you have your first case. I've been talking to James, Dr. Clement. I said, if you have a case, send me the radiograph. I can walk through it and we can get it done. Okay. We started doing this just before COVID. So during COVID, I was kind of stuck. I'm like, what can we do as a community? What can we do if we are not seeing ourselves, if we're not going out, if we're not meeting anymore? So I started a webinar. We started a webinar series where I would connect with all my friends. So I have like 100 prosthodontist friends. So from lecturers. So I'm able to reach out to them. Can you do a course for us for COVID? And this guy was like, this is good. Looks like a fantastic idea. And that's how we got started. If you see right here, I was looking for oral surgeons who could.
Maybe the button on the triple button that would bring that down. Yeah, is it a touch screen TV?
Yes.
No. But I saw the cursor. Oh, maybe the pad on your.
It's okay. You don't need to see my face. I'm right
Yes.
there.
I think it's
Yeah.
okay. That's good.
Thank you.
All right. So that's how I got to meet Dr. Jackson.
Yeah.
So so I'm on online looking like, okay, an African American oral surgeon in Virginia. Okay. Most people want to do this for a fee, but I was looking for someone who could give a course, a lecture on, socket preservation, because that's where you start. We take our teeth every day. Why don't you preserve the socket? Because if you preserve the socket, you're going to have an implant. And you get paid for it. bone grafts and membrane. So you charge for the bone, you charge for the membrane. That's about $2,000. And we take out it, we sew it up, and and some insurances pay for it. So you just have to find out. And some people pay, and just if you tell them, I want you to keep your teeth, people will do that. So you're adding that. So like socket grafting is a good idea. So we began to take this journey all the way to different countries. So I've been to Kenya, I've been to Ghana, so I've been to all the dental schools. So I have an outreach to all the dental schools in Africa. I looked at them, I'm okay, they're about maybe less than 200. So I reach out to them one-on-one, and we take our lectures down there whenever we can. Trying to heat up the lag here. There's a little lag between this. Okay. So that was so I went to Kenya for an outreach with the church, and this dental student was there, and she was like, I want to learn. So I'm like, as part of the outreach, I was doing implant training, and she sat down there, and we began to talk just like this in this room, just like that. And she was able to come here. She was here. She was one of our first students. She went to the embassy, applied, and she got a visa. And I, you know what? I'll try and get you a ticket. And she made it out here. So I'll just move it pretty quickly so that we get to it. I'm originally from Nigeria, so I always have that. So I keep going back to say, okay, I trained as a dentist in Nigeria. I never heard about implants. I mean, so I know most of the students, they've spent 6 years in dental school. They don't have it's as though maybe there's no resources, they can't afford it. So my goal is to make sure that every Nigerian dental student graduates having touched an implant before. So I take the implant with me, I take this kit with me and a model with me, and I go from school to school. This is an implant. I know you're coming to the US, and when you come here, don't be lost. I want you to, this is what it looks like. This is what it takes to do it. So I run a little class. Like I said, from Nigeria. Nigeria is an interesting, very great country, cultural. The largest churches in the world are in Nigeria. Nigeria is a place of there's a fierce Nigerian police. You don't mess with them. And it's quite a fashionable place. And one of the things that we are trying to get Dr. Jackson to go for is a Nigerian wedding to just experience. It's an experience.
When I call you.
Okay, very good.
Yeah.
Very
The
good.
Yorubas have a wonderful culture of weddings, and once you do that, you just have to go with what goes by the side. It's called jollof rice. You can't go to you have to taste it to know what so many things go into in Nigerian jollof rice. But let's see here. All right, so this is jollof rice I was talking about. You got to add the dresses. Everybody dresses the same. It's called ashwebi. Everybody dresses. I mean, people spend millions just to hold a nice wedding party, and it's just what I believe. It's a cultural thing, and it's a way people survive the economy, survive whatever goes on in their lives. But I think it's something we should experience. And in Ghana, hopefully, I'm hopefully going to be in Ghana in December. We can. So this is just a little bit of a journey. I've been to UNC, and I did my pros training in Michigan. And today we're here discussing how prosthetically driven implant industry. So somebody comes to you, or you notice they come, okay, I'm missing a tooth, and I want to put a tooth there. I need a tooth, and I don't want to do a fixed bridge. I don't want to alter the two teeth by the side. There's nothing wrong with it. No caries, because that's what we tend to do. If somebody's missing something, what you're going to offer is what you have. Okay, I'll get you a bridge, or I'll get you a removable based on whether they can afford it, right? A bridge is of 3 crowns. right? A bridge is the cost of 3 crowns. So if the crown is $1,000, a bridge is 3,000. Just to say, depends on the material and the insurance. And you're saying, okay, can I get you an implant? An implant you could charge about 2,500 for an implant. So instead of doing a bridge,
Just for the whole thing? Or
it all depends. So if you buy the implants, these implants are like bio-rising implants are like three.
So to answer your question, the implant is 2,750. And then the general dentist can charge between 1,200 and 1,500 for the restoration. So that's a 4,000. That's the answer to your question. And every implant that you place, you should be placing bone graft. So that's how we make money.
So the person comes, so you're thinking of, so it's all about the planning, treatment planning and talking to the patient. And if you have it as something you can do, you're not going to think about a bridge. Because if a single implant can be placed there, then you're going to offer that as an option. Okay, we can place an implant there. We don't have to touch alter the tooth teeth by the side. We can place something there, and you can give the patient just options. And you can have one thing you should have is a model.
Mhm.
It's a
Yes,
model
an educational model.
so that they can see what's, everybody needs something like this. So you can take a look, so you can show the patient, okay, this is what we're going to do. We're going to screw the implant in your bone and we're going to put a tooth on it. So that you're able to explain and you're asking yourself, and before you can do that, you have to ask yourself about space. Do you have enough? You have space. So you have to think about the restoration. So you have to have the restoration in mind first before you place the implant. Can you put a tooth there, or can you put a set of teeth there, or full arch? Does the patient have enough space? So that is what you should be calculating. You take an impression, you put a denture tooth in that place, and you see it kind of helps you with the angulation and direction. So can you restore that? Can you restore that? So you want to start with the end in mind. If you can't so I end up getting implants that have been placed and there's no room for a tooth. Because you must have a minimum amount of space. The crown has what's the size of a molar?
in terms of dimension.
Yes, width and height. And you should have maybe 7 to 8 by width, right? You should have that space there. But if you put an implant, or maybe there's been super eruption, right, over time, and there's no more, you put an implant there, you can put a tooth there. Because if you put a small tooth there, something's going to break, something's going to give, and the tooth will not look natural. It will not have a good emergence profile. So you need to think all about that. So it's good to always start with the end in mind. So put a tooth there, because you want the implant to be centered. You don't want it lopsided. Because your crown, the way it was made initially by the creator, there's a way the crowns come out. It's just beautiful to see. And when you do yours, can you replicate that? Can you replicate form and function? Because if you don't replicate form and function, you're going to have parafunction. You're going to have issues. It's not cleansable. It's a collector of food. There's going to lead to more periodontal issues. It's like, one bad thing it has a series of effects. Because if your crown does not have the right shape, if it's over contoured, then there's going to be some inflammation. And implants, if you have periodontitis, there's something called peri-implantitis, inflammation around your implant. You would have done your good job of placing the implant, but if the crown is not restored properly, it's going down the hill, and that is what $4,000 going down the hill. So it's all about the planning. So think about it and have a model, and so there's some things that really do matter. Once we're doing that, you want the crown. Like I said, you're thinking about occlusion. So you have to think about it. How is your crown you're making, how is it going to meet it? What's the relationship of the tooth with the opposing and the adjacent? So you need to think about occlusion once you're so everything works together. You cannot place an implant in isolation. You have to think of how you're going to restore it. I mean, I might say this like 150 times because it matters. Because placing the implant is a 20-30 minutes procedure, but trying to restore it. And in placing implants, you are thinking, if it's not properly planned, you're going to get into issues with misalignment. Like I said, you don't want it to be lopsided. You want this. This is a picture of an implant that was placed somewhere, and because of poor planning, it's more your implants. Okay, you narrowly miss this tooth. Are you going to continue the restoration just the way it is? Okay, we place the implant. You are trying to make it centered, right? So you missed it.
And
So-
if you look very carefully at that, if I'm not mistaken, that's going to be a maxillary arch.
Mhm.
This person has a diastema. So definitely that should not be next to the central incisor like that. It should be closer to the lateral
Mhm.
with the understanding that there's going to be a space next to the central. But the pilot drill is starting in the wrong spot.
So how did this happen? How are you going to prevent yourself from doing that? Is what we are here. That's why we have this meeting. That's why you left your home. How am I going to do something? So when I take a photograph, it's always good to take an X-ray of what you have done. When we go to Cancun, we do CBCTs of the implant you have placed so that you can see your implant in 3 dimensions. So you see, you are trying to prevent misalignment. You are trying to make sure that your occlusion is right. You are trying to make sure that hygiene is cleansable and that aesthetically it is pleasing. So that is your goal. So how do you attain this? It's all about the planning. So you're trying to place the implant. So each implant you have has sizes. So the implant has a diameter and a length. Each implant, any company that you go to, your implant has a certain diameter, and it's all based on the available space. So you are trying to put a crown there, you have to look at what you have. So you have to select. You have to plan the implant. You're not going to get to the surgery days, but what implant will you have to plan it. These implants are expensive, $300. If you buy it for $100, that's good, but $300 needs to be planned because once you open the pack, it's gone. So you need to have, you should have a couple sizes that you want to work with. So with the recommended with the promo we have, there's a couple sizes that you want to have. For like a lateral, you're thinking about a 3.75 by 10 or by 11.5. Because you're trying to replace a tooth with a small diameter. You're not going to put a big implant there. For a molar tooth, you're going towards a 5 millimeter in diameter by 10. Usually 10 is the standard number to go by because 10 for length, because you're trying to avoid hitting the sinus or hitting the IAN. The nerves are waiting for you. They're like, hello, keep coming, keep coming, keep coming. And the patient is numb, okay? Patient is numb. So you have to know, you have to measure. It's something called precision. You have to know each of this. Let's pick up one of your drills.
Yes, let's
And
do
then
this.
just pick up a drill, and you can see that it is graduated. There are lines in there. So, and those lines correspond to a certain measurement. So it starts from 4 millimeters. The next line is probably 6 millimeters, and you can move on to 8 millimeters. If you see on your kit, there's a measuring tool there, right there. On the way your left hand is, if you move a little closer in, go in. Where your thumb is, just slide right there. Right, you see it? Right there.
Yeah.
Yes. So if you pick a drill, just pick a typical drill. So yeah, so you can tell.
Deep. This is 15 millimeters deep.
Okay.
12 is going to be at the bottom of the double line. 10 is at the top of this.
Right. Good. You get it?
So yes.
So the top of the line, you can see what are the numbers on there?
So there's 0, 7.5, 9, 10, 25, 12, 15, 18.
Good. So
If I
yeah.
hear that.
So based on so it starts from a 0 to 7.5. So based on the implant you're trying to place, you would measure, you use that to measure. So maybe we are going to 12. You don't want to go more than 12 in
And
length.
every single item in there has the same demarcations. So for instance, if you are utilizing your pilot drill, then yes, you'll notice.
So if you see, it's already, the diameter is on there. So the diameter is a 3, this is a 3.4. So that is the diameter, but the length is what you have to look at. So each of them has like, so you're trying to put maybe
10.5 at the top of the single line. So if you're
4.5
you're
by
looking to
12.
see, okay, did I go to the top of the double line? That's
So
where
this is the
of the items are
this
have the
goes in
same.
okay, so it's from this
This one has the same
So if you're
demarcation,
going
even up to your
here.
paralleling pin is identified
So
with the
12 is at the end
demarcations.
of this
Okay.
particular line.
Even up to your paralleling pin.
Okay,
Your
yes.
paralleling pin
So
is gonna
12
have the
ends.
same
12
demarcation.
and the
So
4.
let's say
12
you
ends
drill
right
right
here.
here.
Yes.
Now you put
So you
your
should have that, and then your
to see the
assistant
same
should
reference of
know that too. So you guys,
So that we-
because when you're drilling, it's moving, you're probably not seeing it, and somebody else is seeing it.
But
You-
there's
I'm gonna
some.
show it to
Oh,
you.
They are stoppers. Some of them have stoppers, and some of them have surgical guides
Yes.
that
okay.
prevents you from going deeper than you planned.
Right.
You know, so
Different
that's a
kits,
good
so-
question. She picked it up and said, "Do they have stoppers?"
Exactly, so
That's-
we are teaching you, and look, everyone has this book in front of you, you have it right here.
Rotator.
And you're gonna go in this book on page 19. And you will see a large scale of the same reference. Well, we'll look on the front, Isaac. No, it's this one. Okay. Oh, yes, thank you. So what you're gonna do is on page 19. On page 19, you'll see the same kind of blow up of the demarcation. Doctor, you're in the wrong book.
Okay.
Page 19. And it will have a blow up of the same demarcations, and that can be a reference for every instrument in your kit. We are teaching you on a kit called Bio Horizons. Bio Horizons is, let's just say, efficient, and it is very useful, color coded. You will be introduced to a Bio Horizons rep. The BioHorizons company has provided you with bone graft membrane implants, motors, models, and such. And so we are showing you, this is this kit. But part of our job is to let you know, this is not the only kit there is. And there are other kits that have other little characteristics that make them different. For instance, BioHorizon, you have to look very carefully at these measurements, these dashes. Your eye will get accustomed to it, but there are other kits that actually have a stopper. Like the drill bit is not any longer than 8.5. The next drill bit is no longer than 10. So if you drilled in, you couldn't go any deeper. This one allows for the flexibility of drilling deeper if necessary. So we do want to make sure that we kind of put that out there. It's just that we really appreciate BioHorizon for providing everything. You know, if I found the kit that had the stoppers, well, maybe they wouldn't send us the models, the bone graft, the membrane, and the implants. I don't want to limit ourselves with the kit. I want you to just realize, kind of like a technician, you have a lot of tools in your armamentarium. Makes sense?
So it's about the planning. So if you're planning, we're trying to put a 4.5 diameter implant by 12. So that is so you need to, how do you get to place a 4.5 implant by 12? So you go, so the guys that started this implant procedure started long time ago, and they talked about it, doing it gently, doing it atraumatically, doing it, sequentially, and intermittently. I mean, those are the words that were written in 1969, and it still holds true today. When I say gently, atraumatically, you're not trying to bring a lot of trauma. You're trying to do some. I saw some surgery going on the other day, like, no. This one you need to go gently with a lot of irrigation. Because once you're going intermittently, because when you take the drill out, your water goes in to cool down the bone. Because if your bone doesn't cool down, you're going to burn the bone and your implant is going to fail. So you're going gently, atraumatically, intermittently with a pumping action, and you're going and you're trying to stay in the place because you're moving. These things are moving pretty fast. So the usual setting is about 1,000. So there's something called on the motor. We'll turn it on in a few minutes. I want to make sure we marry what we're talking about with what you're seeing. So your drill, we're going to do some of that later. Your drill is rotating at 1,000 RPM. So it's pretty fast, and you want to stay right here. You want to stay where it's all about the planning. And this kind of planning is done. Tomorrow we're going to show you the CBCT machine. It's 3D. So you have to use that. I think without 3D, you're likely going to get into some errors. And today that technology is available. We're not going back. We're not going back on that. 3D, so you can plan where your implant is going. So this is a 3-dimensional rendition of the space you want to put your tooth. So how are you going to be able to put it there? So with your planning, if you have a surgical guide, you go straight right there. If you don't have a surgical guide, most time for your single implant, Dr. Jackson doesn't use surgical guide, because she does it all the time. And so you're trying to place this implant right there, you're trying to put it in the center, and you're going slowly. So you start with the pilot drill. You put a little the pilot drill is usually 2 millimeter in diameter.
This is going to be your pilot.
First drill.
The first drill, and it's going to be sharp and pointy because it will be the first to access the bone. Also, when you look at the little implants, I gave everybody 4. They're going to say things like 4.6 by 12. 4.6 is the diameter that Dr. Anarobi has discussed. 4% are generally for premolars, or it's going to say, and 4.6 by 12. 12 is the depth. So again, on your sheet, you're looking for where is the 12th mark, 12 millimeter mark. So that would be how deep you're going. And then every systematic sequential drill will get you eventually to the 4.1. So that now you can put in a 4.6. Does that make sense?
So the implant expands to
Yes.
4 point.
Right.
Yes. So your
Implant's going to be 4.6, but you start at your pilot and then you go to the next one and then the next one and then the next one until you get to just shy of 4.6.
So you're not going to 4.7.
Right.
You're under prep so that you can have some primary stability.
Okay.
Because if you make it exactly the same size, then it's not going to be tight.
Correct.
So you want it 0.5 or 0.6, just a little bit. And all depends, but this is all dependent on the bone density.
I'm learning that too.
And bone density is given by the anatomy.
Right.
Because you can tell what kind of bone it is. So without even using any technology, you already know that, in the mandible, you're going to have more cortical bone. So which is D1 and D2 bone. So this slide is a good one to take a photograph of so that you can remember. So if you expect soft bone towards the posterior maxilla is going to have D3 and D4 bone. So it's already there. So you're not trying to. So when you are drilling, you are going to drill. You're going to under prep. Your drilling is going to be dependent on the kind of bone, what area you are working on. So remembering this all the time just kind of helps you to say, okay, this is where we are. So we're not going to follow the sequence. We're not going to follow the, each of these drills each of the kit you're using shows you exactly what to do. But this is if given that it is there is a D1 and it's hard bone, so you can drill, you can follow the sequence. But once you're drilling, you kind of know. After some time, you know. Once you drill, you will notice that wow, it just dropped. That means you left the cortical area and you are in the cancellous area, and it's pretty soft. So you're not going to keep drilling. You could just stop right there. So I'll show you. Yeah. So bone density. You can see bone density from the CBCT.
So, okay, you can tell from the CBCT.
On the CBCT, it tells you. So once you put it, so tomorrow we're going to see that when she comes in. Once you put the cursor in a particular area, there's something called Hansfield. There's some Hansfield unit. You can be able to tell what the density is. So once you know the density, then you'll be able to walk with that and place the implants in that manner.
Yeah, I've heard of someone saying that they tried to place it might have been my 30th time, and that they go in and it just sucks it up. Like, so that would be, we're talking like in a D3, yeah.
Yes.
What sucks up?
The implant, it just feels like it falls
into the sinus.
space. No, not into the sinus, but it's so soft that
Like,
yes, so I just was in on an all-on-X case and
Good.
just, I wanted to witness one, and I was asking because I didn't want to bother the surgery, but which is why I'm like, I'll rather go take a course, yeah, and so he was saying, I said, how do you know when it's locked in? Because it was a periodontist and he just free guided it in. He says you would tell when it just feels like it just sucking in.
yes.
Like there's no resistance, basically, is what he's saying.
So you go with the first drill. There's some videos that I have to show you those videos today.
Okay.
I want us to see it. So you can have a sense of what it looks like. Because
Okay.
once it drops, once it becomes very soft, you will know. When something is hard, you are trying to drill, and it just takes some time. But once it drills, there's a little drop. It just goes in, and in trying to go in, you want to make sure you are keeping it in the plan. Because if you don't, things can move, and you're trying to make sure that your tooth remains, you're trying to place an implant right here, and you go a little bit and it's soft. The fact that it's soft, it means you can actually make a mistake. Because if it's soft, that means you can move it, and it's not going to be in what you plan. So you want to make sure that even if it's soft, you are still keeping your direction. So a guide is helpful. But if you don't have a guide, you just have to be sure. So once you finish taking it, we talked about the guide. You talking about the guide?
Paralleling pin.
Yes, the paralleling pin.
So actually, yours got.
So you're saying that I need to go find a CBCT right now?
That is helpful. Or you can send the patient. You can send the patient to send someone can take it. Take that CBCT and you can take a look at it. You can use some of them have the software so you can actually plan it.
Yeah.
So a CBC is helpful if you're not going to, it's a lot of money. $20,000.
25?
These are all.
Depends on it depends on the manufacturer.
Yeah.
It's the same thing. So let's say you drilled your first osteotomy with the pilot, and now you're confident and you drilled with the next level. You want to double check your position, place your indicating pin in, take an x-ray. You're new at this. It's fine. You take an x-ray, but be sure you put a floss through the hole so that you don't, if the patient, you don't want it to fall back. Just like with the, I think they're called the bands, for orthodontic bands, we used to put floss through them so that the person wouldn't choke them. And then you place your pin into the osteotomy, take an x-ray, reference, do I need to make a minor adjustment? Is it tilting too far to mesially, or maybe it's not deep enough. You can see that your inferior nerve is way down here and you under prepped. So it gives you a confidence, okay, I have more room to work with.
And right angulation.
Exactly, and the right
And then
angulation.
you just go back to the pipe.
No, you would go back. If you need to correct,
Yes.
then you can go back to your next drill because you've already in your osteotomy and you can make your, what did you call it? New angulation or re-angulation.
Okay.
Also, the reason I use these indicating or paralleling pins is for socket grafting for immediates. And I'll talk about that.
So the reason we talk about that is so that once you place your pilot, you start your pilot drill, you have to like take an X-ray. So you can tell whether you are in the right place. Should you continue? Have you made a mistake? You think the bone is not flat. So when you take an X-ray, you think if you'll be surprised how much things look different if you do not, check. So you place your first pilot. So you're trying to get in here. You'll be so surprised sometimes that once you go, your pilot is usually you want to stop at 6 millimeters. You're going to put a 12 millimeters implant, but if you start at 6, you can make some corrections if you already made a mistake. So you're trying to place it here. Sometimes you'll be surprised it's so close to the tooth. You're like, wow. At that point, you can still correct it if you're not using a guide. So you want to take an X-ray because you need to know where the nerve is. You need to know where the sinus is. So once you have all that, so with CBCT, you can plan. With CBCT, you can tell where the nerve is. With CBCT, you can tell whether it is in between or you can place an implant there. So all that, I say that I'll continue to say that you must do that to be able to get a good outcome. There's a guy from Sweden, and he talked about the criteria for implant success. What you are trying to achieve when you finish placing your implants. The implant should not be moving. If your patient comes in like an implant is moving, that is a problem. Your implant should not be moving once you finish placing it. So how do you? So we're going to get to that point now. You don't want any peri-implant. You don't want any radiolucency once you place your implant. So once you do that, so this is what you are trying to. This is you don't want any bone loss. We'll be talking about bone loss. Or patient comes in, we place the implant, and all of a sudden you don't want this bone to get up to here. Like if you don't have bone, and this is all that you have. So most patients come in after a while just because they didn't clean. Some people think they can place implants and they don't need to brush their teeth. Some people have this point, oh, I have implants, I'm good. I don't need to brush my teeth. If you don't brush your teeth, then you're going to have, bacteria there and you're going to lose all your bone. I mean, you lose your bone and your tooth is going to come out. So you're trying to make sure there's no pain. You're trying to make sure there is no infection or nerve or any paresthesia. This is what you're shooting for. So you should have that at the back. So how do you achieve it such that there's no peri-implantitis? So it comes from the same thing that we're talking about. There should be a lot of irrigation, and you should follow. You're not going to jump from like 2 millimeter diameter and go to. Some people try to do things quickly. They just want to move from 2 and put 4. You need to increase it slowly, so you go from 2 to 2.5 to 2.8 to 3.2. So that is the way to do it. You're not jumping, you are trying to place it slowly and following the rules. That's the only way you can get a good implant that has some primary stability. Primary stability means that when you place the implants, it is so there's something called Newton centimeter in terms of the force at which it is tight just from placing it. So the implant has not also integrated, but when you place it, it is tight and you can close it up and allow it to heal. So that is what we're shooting for. I'll show us some rules here, and I want us to get into it, so that we can just I'll show this rule. Once you are placing your implant, there are some simple rules that you can follow. And one of the rules is that from this is your adjacent teeth. You want this to be at least 1.5. That from the adjacent tooth to your implant should be 1.5. Should be 1.5. So you need to calculate. If from here, let's think about it. You can draw it in your note, put a tooth here, put a tooth here, and put 8 millimeters in between. So if you have 8 millimeters in between, what kind of implant? What's the size of the implant? So just draw a tooth, okay, right here, something like this. Is from the CJ to the CJ, just put 8 millimeters. And the rule says that you need at least 1.5 between, from here to here is 1.5, from here to here is 1.5. If from here to here is 8, what size of implant would you place there? 5 millimeter implant, right? So that kind of tells you what size. So you're not guessing. So you're planning. If you have 8 millimeters in between, and if the rule says you need at least 1.5, 1.5, so that's 3 millimeter already. So all you have left is what? 5 millimeters. So that is the size of the implant you're going to place. So this is something you always have to deal with. And if you need to put 2 implants in there, from one implant to the other, you need at least 3 millimeters. You need that because you are trying to place a tooth there, and your tooth should have a good emergence profile. If it's too close, then you have a black triangle. Now, if you have a black triangle, it's a place where food is going to get, your gums are not going to, if you have a black triangle, then it's a place where food just gets packed there. So you want to make sure. So it's part of the planning. We could talk about planning. These are the rules that you would follow. And one other rule here, especially most of the cases I've seen, people who want to start is most people who need implants, they are missing their central incisors. Most people who are placing implant for the first time, that's what I've noticed, that from people who have taken this course, they call me, oh, it's the first. That's more difficult to deal with.
Yeah, that's a tricky one. It might not be the first one, because it's the third angle from the central incisors. It's not straight up and down like 6 o'clock. It's going to be angled to compensate for the position that is going to go over the mandibular teeth. So quite frankly, your first one might be better to be a premolar.
Because the premolar, the maxillary is far away from your sinus, and it has enough room, or a molar tooth. So, but if you have to do a central, the access, you have to angulate, you have to plan in such a way that the access is coming in this area. You don't want your implant, because you can place your implant like this, right? It looks like, oh, it looks nice. Oh, wow, I put it in the bone. You don't want your implant to come out. The access shouldn't be in the facial. You want it to be in the cingulum right here. So you need to put a tooth there, do a suck down, and drill from there if you are planning that. So you always have to. So these are the rules that we must follow. And once you do that, so I would say this shouldn't be your first case. Your first case shouldn't be the central, because it's much more difficult than. And you want to make sure that it's far away from the buccal bone. This has to be protected. Your buccal bone has to be protected, because you don't want your implants, showing through. You don't. If you do that, it's almost going to fail.
It could even be a two-rooted premolar. Place your implant in the palatal root.
All right, so I would show up one more slide here. Then I want us to just get into it and just and go from there. Like I said, you have D1, D2, D3, and D4 bone. That is something, and you're drilling according to, so each of the implant companies have their rules. So you have to follow. After a while, you kind of figure out how to do things by yourself, but each implant company gives you just a way. This is Nobel, right? Nobel, I think I kind of believe this can be used by any system. So it tells you there's very hard bone, which is type 1, type 2, type 3, and type 4. So you have to create your osteotomy based on the density of the bone. If the bone is very hard, then you need to drill. If you notice here, these are all the diameters, right? The implant is a 4.1 implant. So we are going to place the same implant, but the density of the bone is different. So you have to follow a particular way of doing it based on the density of the bone. So let's go with very hard bone. If it's a D1 bone, you are going to follow, you go with the pilot drill 4.2. You start with that at the RPM. We'll do that as we go, but you are just going to follow. This is 4.2. We go 2.8, 3.5. You can actually stop here, and here they have a profile drill. A profile drill is where you just you prep just the coronal portion of the osteotomy, so you're not going all the way. Okay, so for the hard bone, if you notice, you go all the way and you place your implant. If you have like soft bone, you don't have to drill all the way because the bone is soft. So you can actually stop. You can stop at 3.5 for the soft bone. You don't have to create your osteotomy, keep drilling. So if you notice here, you don't have to go. You can stop at 3.5 and you can still place the implant. If your implant is very, very soft, then you can stop drilling at a 2.8 because the bone is soft. You don't want to, if you drill all the way, then your osteotomy will be too wide and you place the implant and you don't want your implant so and you've already opened the implant and so you'll have to probably leave it in there and allow it to heal. So that's not the best. So that's what we I'll show you one video here. Once we change that, there. So your pilot drill, we're just going to go with the first drill. So you're going 2.8, 3.5 at the same length. You are trying to put a 4.2. What do you have? What implant do we have?
6 and by 12.
By 12.
And they also have a 3.8 by 12.
Okay, cool. We'll watch one little clip here and we would go from there.
What kind of system is that?
So this is Strongman. Strongman. I think it's it's a good product, but it's expensive. I mean, each implant is about $500.
Versus 3.
Yeah, that's just I mean, it's just like expensive for nothing.
It looks like though that are those stoppers on there?
Not exactly.
Why?
This one. So the colors is just based on the diameter. So this is so this system has a needle drill where you can then before you go, a needle drill is just pretty like you said, you have to watch out for the length. So once you know your implant, you are trying to put a 4.6 implant. So that is where you want to stop. So this implant has different parts. Like you have pretty much the same thing like what you have here. Well, we'll see. So this is what we talked about for soft bone, medium bone, and hard bone. So once you know you're working with hard bone, then your drill, you're just going to go with what it's like, like just the default steps. So you're going to, but if it's medium bone or soft bone, you don't have to drill all the way, because if you do, if you drill all the way for very soft bone, then you're not going to have primary stability. Then if that happens, you'll probably have to place the implant, do some grafting, and make it and put a cover screw and put sutures and allow it. You have to give more time for osseointegration to take place if that happens.
You could also decide, let's say you were planning for a 4.6 and now it's soft bone and there's no initial stability, you can put in a 5.2.
So that means you have to
Another implant.
another implant to make sure that you have that. So you really have to plan. So this is an example of three different. It's the same size of the implant for three different bone densities: hard bone, medium bone, and soft bone. So you're putting, which is exactly what you have there, 4.5 by 12. And these are the three different bone densities. So you have soft bone. With a soft bone, it is more of cancellous bone. So there's a lot of holes and spaces. But here it is harder. I'll stop once it gets to towards the end. So for a soft bone, it is ready. You don't have to drill. It's the same size of the implant, 4.5, but soft bone, you can stop drilling. So for soft bone, you can stop there. For medium bone, you can stop at 3.5. Then for try to go back to that. Watch it again, and you have to make sure there's once you place the implant, it should be you shouldn't go more than 50 Newton centimeters. So if you do, because the tighter it is, you can generate heat, and heat can lead to failure of the implant. So you have to follow the manufacturer's instruction.
That's a special kind of wrench that you just see on that image there. It's called a torque wrench. In your kit, you're going to use your surgical ratchet, but a torque wrench will tell you how much torque you have actually on your implant. I can show you a torque wrench.
So what's your favorite system?
So I work at our office. We use Dense Supply Sirona, Astra. That's what we use.
That's Place Around.
Yes, so that's what we use. Pretty much the same. It's the same thing all the time. So you just make sure there's irrigation and you can tell that it's soft bone. If it's too soft, then you can stop there and you can have some primary stability.
So in my office, I purchased an office last year, and the guy left the Nobel care.
Okay, Nobel is a good one. Nobel is a good one. Like some of the implant systems have like a needle drill, like this. A needle drill is just like a pinpoint, so that when you place your implant, it doesn't dance around. So it gives you can plan. So you place a needle drill, so in trying to make your osteotomy, you can raise a flap, or you can use a tissue punch. So you don't have to raise a flap, but you have to plan very well if you're just going to use a tissue punch. So you just take off that portion of the tissue. So all that. So this is an example. This is your first case, right? Just imagine this is your first case, and the patient comes in. That's it. So you should have an idea. So this is posterior mandible, is probably a D2 type of bone, and you're going clockwise. You are going clockwise with a lot of irrigation. I mean, that is what you need. So you have to make sure that there's a lot of irrigation and you are drilling at a certain RPM. That fast. So for this implant system, they say 800 RPM. I do 1,200 every day. That's that's what has worked for me with Denside Sirona. So if it's too soft, you want to make sure that you stop at the setting. Okay, that's your.
So this is the 2025 kit. What we've shown you all on is something that works and is useful, but they have a new edition kit This is a torque wrench. You would put the attachment on, let me show.
And the markings on there.
So you put the attachment on as if the implant is in. The implant's gonna be in here. The torque wrench will allow you to show you how, on this gauge, how much torque is in there. It's an extra step to the measuring tool that can be very useful. So the implant's in, meets this
So
one,
you-
and this will tell you, okay, I've torqued it
It's
to
free.
15.
So like you can change.
It'll stop at where it's maximally torqued.
Okay.
That's
So it shows you where you.
yeah, it'll show you, okay, you may have put it on your motor. I'm gonna stop at 50, but I wanna put it on the implant and see, is it 50? So the implant's gonna engage here. And so you keep your finger on it, and then this, you pull it back a little bit and it'll show you, see the little markings? It'll show you, okay, you're at 50 or you're at 15 or you're even at 100. It's a torque wrench. It will tell you how much you've torqued it down into the space.
Well, one thing you can do is that if you don't to start, you need to there's a kit you can get, like a kit for multiple implants. It's on eBay, it's like maybe $100. You should have that. So you can actually, restore implants that you did not place by yourself. So you should have a torque wrench. You can't.
I do.
Yes, that
Of those that
Yeah.
you turn the.
yes.
I don't even have, it's like a handpiece.
Yes.
And you use one way is the counter, the certain screw, yeah.
It's one of the few measuring tools that I do agree with, that this torque wrench can be helpful.
Lastly, here I'm just going to show you back to our planning. So I'm thinking, so this is implant, planning. You have to have some kind of, it's either you scan or you take an impression, pour it up, and you put a crown there, so that you have enough space. Once you deal with the restorative space, then you can look at your CBCT. Your CBCT, you can measure with your CBCT, you can tell what the density of the bone is. So there's D1 to D4. So with the softwares for implant planning, it tells you what. So the patient comes in and needs an implant placed, and you can tell where the line is the density of the bone. Right here. You can see this where this line is. That's the density of the bone. So that kind of determines what you need to do in placing the implant. If it's hard bone, it will tell you where it is, but this is between, and this goes by anatomy. You remember that first slide? Once you're towards the posterior portion of the maxilla, is between D3 and D4. And so you're planning, you can tell what the length is, but you don't want to go in and get into the sinus. You want to stay 2-3 millimeters away from the sinus. So you can determine what the length is, and you can determine what the diameter is. Then once you do that, if you're using a guide, so in order to place the implant, you could raise a flap or use a tissue punch to make a hole and just place the implant. So we're going to go ahead and let's place some. Let's make it yours. Church me. We'll go from there.
It's 10 o'clock. Breakfast is ready.
Okay.
Breakfast consists of fruit and croissants and water. I'm a big water drinker. Lunch is also available in the kitchen. Lunch will be sandwiches, turkey and ham or turkey or cheese and vegetables. You can bring containers in here, specifically a small plate with something to nibble and or a cup with some water. We will be placing implants this morning. The models that you have, I start everybody off with models that don't have gingiva, because I have learned in the past that sometimes it's a little slower for folks to do the suturing. So these models do not have gingiva. The idea is, let's say we're going to start on the bottom left. You're going to need to utilize your cell phone holder. This is because we do not want people placing implants in the mandible in their hand. We're not cheating. We're going to get you ergonomically stable and positioned appropriately. Each of the little pieces have a metal post. You are going to place your implant off center of the metal post. Don't drill into the post because that's not a good idea. So perhaps it's off center, slightly closer to the mesial. And we're going to go each step from the sequence of the drills to get you to place an implant. One of the beauties of having a small course, we usually try to have 6 to 10 students. You all, clearly it's 3 of you. So we have implants for 6. That means each of you are going to have 2 additional implants to place. So this is all working out just fine and dandy. But that would be the next step. So we're going to place an implant in the right side of the mandible, the left side of the mandible. We're going to utilize our kits here, our cell phone holder. I can help you move it closer, or I can just put you in that seat.
Yeah, I can move over.
And then we'll also place one in I have another maxillary, because when Julio comes this afternoon, he's going to restore a maxillary anterior. And then tomorrow I have more models with gingiva. And the idea is going to be that you're going to cut the gingiva, lay a flap, keep the flap down, place your implants, suture your flap. Sometimes it takes longer to suture than it does to place the implants. So let's take a quick break.
Okay.
And food, okay? All right, come on, right this way, folks. Thank you. Okay. You guys all right?
Just two slides here.
And also, I didn't show you this stuff on the whole sheet on all your parts for the afternoon.
All right. As we continue, one thing that we need is some risk assessment. So you want to place implants, so the patient comes in, you want to do some kind of risk assessment. I know we just talked about bone density. Another thing we need to think about is just history. You have to take a good history of this patient because if the patient is a smoker, cigarettes, that means you need to consider all that. Is the patient diabetic? Has the patient lost implants before? Is the patient taking any anti-resorptive agents? What medication is the patient on? Any SSI, proton inhibitor, what is it, alcohol? Has the patient had head and neck radiation? So you want to like really make sure you do your investigation about the patient, because if you do not consider it, if the patient is a smoker, it's more likely for the implant to fail. If the patient is diabetic, let's just go with even diabetes. What's the A1C? If the patient has an A1C that is more than 7, that means your implant is likely to fail. So you have to consider, as the patient had a failed implant before, so you need to find out that side. So so there's some research has been done and said, okay, if the patient has failed an implant before, sometimes you can go back there and place implants with some grafting and it to succeed. But these two, so there's a study that was done by there's a paper by Don Curtis, patient-centered risk assessment. We have to like do this and be sure. So if patient comes in, I want to place implant, you have to have like a list just to be able to check. Okay, I'm not diabetic. If I'm diabetes, your diabetes is under control. And if it's under control, what's your A1C? If it's less than 7, okay, we're good to go. If the patient has A1C more than 7, not a good idea that you should do that. So you need to watch all that. I know, okay, we want to place implants, but if your A1C, if the diabetes is not under control, patient is a smoker, you want to So like I said, this is a paper. I can send this paper to us by Don Curtis. This is like some scientific evidence estimating the risk. So you must do some risk assessment on your patient so that you don't. So doing their study, they talked about the amount of bone that is available. So that is something we must. If the patient is so for every patient I see, I want to find if the patient is any periodontitis going on. So you want to do do your examination and find out if the patient is having periodontitis. If the patient needs deep cleaning, if you have a lot of bone loss, you want to stop and be sure that perio is under control. If not, that if you have periodontitis, you are likely to have peri-implantitis.
Right.
So something is bacteria is on there. So if you're so not everybody is a candidate for implant placement. So you need to find out from your patient. So you must take your time, do your risk assessment, and say, okay, if your perio is not under control, if the patient is a bruxer, if your patient is a bruxer, you want to, there's more likely to be screw loosening if the person is a grinder. So when you place your implant, you want to make sure that if you put you want to make the crown is hypo-occlusion, right? So you're not hitting on that. But if you do that, you're likely to fail. So you need to consider that. Is the patient what kind of experience do you have? So you need some experience. When you're placing implant, that's risk too. You must have some experience. So your first case, you're going to do a first case, second case, third case, but so you must consider that. Like I said, implantitis. If there's chronic implantitis, then you want to make sure you hold on first until that is under control. If you need to send a patient to a periodontist to ensure that is under control, then the patient can come back to you. I know you want to place the implant. How is the tissue type? Is it thin? If it's a thin tissue type, there's more risk that that's where things fail. So you have to consider that. You're going to do, a graft. What kind of grafting do you need to do? So you have to look at all that. And if there's plaque, patient is not brushing their teeth. There's plaque everywhere, calculus all over the place. Not a good idea that you should continue. So you should have a little risk. So we talked about diabetes one. So maybe like just 7 areas that you should check. So you should create your own risk assessment paper of that. So patient comes in, they are missing a tooth in number 6, but you have to ask, are you diabetic? Are you a smoker? What medication are you on? Does it affect the healing process? We'll look through something later, but let's go ahead with. So just imagine that you have a good patient and you want to place your implant, and we'll go from there. So let's get started. We're going to turn on the.
Okay, so for everyone, find your power on switch on your motor. That's the first part of how do you use this. And your motor turn on switch. Don't call me and ask me how to turn it on. Okay. Second thing, wait, blocking. Go ahead. We're gonna wait for you. Go ahead. Can you turn it on?
It's in the.
Turn it on. In the back. Good. That's the first step. That's the first. You know how you take an exam, you gotta put your name.
Yeah.
At least we got it turned on. The second step is you're gonna look carefully at each of the marks on the motor. So the first one's gonna say 1 to 1. You see that? And then you'll see a little double arrow, and then you'll see 20 to 1. And then you'll see an actual implant. You're looking at your motor, Isaac. See that? So it says 1 to 1, double arrow, 20 to 1, implants, the implant setting, and then a 20 to 1 with something circular.
Yeah, check this.
Yeah.
It's a 22. So your handpiece is written 20 to 1 on it. So you want to make sure you have that.
Pick up your handpiece. Good. Take it apart. Pull it. Good. That's how you would attach it and put it back together. Okay.
If you see the 20 to 1 written.
If you put your foot on your pedal, everybody organize their feet. Where's your pedal? Again, this is why it's beautiful to have 3 students, because this would have been you all sharing with somebody.
Let me show you a little bit here. So this is how you control what you're doing. So sometimes you don't have to touch anything here if you set this up well. So this is for water. This is for clockwise or anti-clockwise. If you're trying to come out, you can go anti-clockwise. And this is if you're trying to go from just the speed, you can control this with it.
Okay, so the attachments are connected, is that correct? You've got your foot pedal next to your foot, preferably your right foot, if your right foot is. And you're going to push the white pedal first. Just let's hear it run. Got it? Good. Running. How about you? Good. Okay. Put your pilot drill in. I want you to push the back of your handpiece, which will allow for you to engage your pilot into the front of the handpiece. Excellent. And one more time, put your foot on the pedal. Okay, so that's going to be moving to get you to place the implant. Yours is actually set, Dr. One more time. Folu, Dr. Folu. Yours is set for placement.
Yes.
Yours is set right now for drilling the osteotomy. So there's going to be different steps for each part of this implant process. So right now, Dr. Plockins is set at 1.250. Dr. Folu, can you push your 1-to-1 again? One, yep, there you go. And then push the next one over. And push the next one over.
I should be here.
You're in the right
Okay.
spot.
So
She
you can
needs
go back
to,
up.
she needs to.
It should be one on one.
So RPM, you can reduce it negatives to 125.
There we go. Good. And Dr. Isaac, how are you? What, can you turn yours just a little bit so I can see? Okay, so make it up to 1.25. Yep, add plus. Good, got it. All right, I'm gonna have you move yours down. Can you move yours down? Oh, can you move yours down to 850? Let's see if you can do the up and down. Do you see that? That would be up. Bring it down to 850. Good. So we don't really place implants at 850, but if the bone is soft,
Yeah.
then we could bring down our torque, right? So we do want to know how to bring our torque up and down. Thank you. Thank you very much. Okay, so everyone set theirs to one.
I want to.
Yep.
You said it should be set to 1.25.
Yeah. Well, yeah, that's where we start. Yours is good. Can you bring yours back up to 1.25?
So if we're gonna do soft, that would be around. Okay.
Because you don't want to
22.
think of it like a hot knife through butter.
Mhm.
You know, you don't want to, right? You want to kind of go a little bit. Like you can literally go down even to 500 on a good day. It just depends on how the bone's integrity. Okay. Okay. Now let's say we're all at 1.25. We know where our foot pedal is. Can you run it one more time with your drill bit in? Good. Okay. And you hear the sound that it makes, that kind of whistling sound, right? Okay.
So on this, I think the patient is missing 2 teeth from what you have on your.
Yeah, we're gonna do this, the mandible. So first things first.
You want to mark where you're going. So if this is 1.5, you probably put here, then in between you have like 3 millimeters between 2, so 1 here and 1 there.
So
Yes. Yes. So by the time you pay, and you're trying to make sure you're not going on lingual, or you don't want to have the penetration in there. You want to make sure it's in the center, and you're using the arc too. So you're using the arc and be sure that you are in line with their
Okay.
central groove. Central groove those
Before you even drill in there, make sure that this 2 prongs here are facing the front of the room. Okay, because this is your patient being organized in your chair. Turn the feet, because you're sitting on the lady's lap right now, Isaac. We don't want that. No straddling the patient. Make sure her feet are towards, just directly towards the. Okay, let's turn this around. There's a button underneath that will allow, there you go.
Shouldn't this be like here, like that?
Yeah, that's right.
Yeah.
I'm so sorry, Doc.
That's okay.
Hold
Finger
on.
rests.
Okay, and then you can squeeze this to hold it on.
That's it.
Okay, and then when you are working on the mandible for implants and extractions, the mandible must be parallel to the floor. You cannot have the mandible tipped up like you're taking out a maxillary tooth. So yours is slightly tipped down, Isaac, so bring it up, chin up,
To 4.5
Yeah.
inch.
and you will tell your patient that too.
Okay.
I'm gonna put it there a little bit. So you want this to be parallel to the floor, and we're gonna tighten it so that it's nice and tight and sturdy, okay? Good. Yours is good, okay. Next, with your finger pressure. You're gonna, so I did mention this, I'm just gonna repeat myself. The hole is a metal post.
Okay.
We're gonna drill off center from the metal post. Don't drill directly into the metal post, okay? So. So you're gonna hold on to your mandible. And I'm gonna turn a little bit just so you can right there. Okay, put your finger on this so that it doesn't spin, or you can go mesial. Okay, but hold on to your mandible. So you put your finger in this mandible and squeeze. Love. Yeah, it's something to eat. Okay, is it tight? Okay, go, Isaac, you should go. Put your finger over Okay,
Should we be measuring these
so
for,
let Dr. Probably help you with the measurements.
so if it's like there's 18, 15, well, like that.
Oh, you looking for your implant place?
Yeah, like how deep we should.
So that's the 12.
12.
Where's your implant? Your implant
Yes,
is
your
like.
implant is
Oh,
gonna,
yeah, yeah.
So you have to use.
is gonna dictate your depth.
So, well, I was over like there.
This is 0 to 7.5.
What you should be going, Isaac, you should be going in a pumping motion.
Yeah, yeah. Okay, thank you.
So you're going in and out, and obviously you're having some bone is going to be coming out. So you want to like clean out. It's either you clean out to collect, or you clean out to just suction it. So if you clean out and you collect it, you can use that to grab.
The whole.
So you don't have to, you get extra bone. So every time you go in and out, you can actually collect in a petri dish, whatever.
Yes,
chips.
collect your bone
Okay.
particles. That particles are very important for autogenous bone grafting. If I'm drilling a hole in the wall, I'll take out my drill bit and there will be drywall on it. If you drill into the bone, we'll take it out and there will be autogenous bone graft that we can then mix into our bone material that we're using as our graft.
Going in, how's it going?
It's fine.
Good. I was just trying to see.
I was supposed to go to food.
Is this kind of?
Yeah, so you're trying to keep your- you're going up to
rotary for
12.
windows?
So
It's like for both.
Similar, right, don't perfect.
I just, yeah, exactly.
Exactly.
Like,
Don't-
yeah.
Down to 12. So you have
I know
to
it's been a while since you
The
did.
measure was like-
But you know, you know.
Stuff on this. It's a
Do
zero.
it. How do you feel?
The 12 millimeters is the value, right?
Yeah, you're sticking your finger in the person's mouth like that, but that, we're here to practice.
Right.
So do what you can so that you can get the right angulation. Excellent. Excellent. Hold this piece and we'll spin out, like right on the piece.
So you want to make sure if you have, if you are following the central groove if you have the central groove, you have two adjacent teeth, so the line from central groove of the adjacent teeth kind of helps you keep it in the center if you're not using it, guys. You're going in and out. In and out. And you clean, because if you need to remove the bone chips that comes out so that you don't, because if there's bone chips, there's going to be less sharp So you want to clean it out every time you come out. Your suction is there, and your assistant
Okay.
will help you do that. So you are cleaning bone. Usually the suction is right there. You're taking bone out.
Your assistant holding on and supporting the man.
Right.
We're gonna place the green,
The green is what? What is it?
4.6.
4.6 by 12.
Yes.
Okay, good.
Yeah, so your assistant, you can be firm with her or him and say, I need you to support the mandible.
You know, there's irrigation, there's blood, you know. So your mouth is different because it's gonna be bleeding. You have to make sure the person is numb. The tongue is right there, the cheeks are right there. So you want all that out of your way. And
Good, yeah.
So now go to 2.5.
Yes. Yes. So you go to the extent of one drill, take it out. Go to the nether drill to the entire extent of it, take it out. Good. Very good, folks. I'm gonna take some pictures. You guys look good.
Oops, there's one in the next one.
Keep going. And we want this person to bring their chin up. Good. Good. Always parallel to the floor. Because if you start in an awkward position, you have awkward angulation. Good. Maybe put this little thumb on it because it'll spin out. And double checking is fine. You can also double check with this pin. You put your pin in, might not fit yet, but you would put your pin in, you look, oh, looks good. My angulation is looking good. I'm not lumping into my premolar. Okay.
Which pin did you use?
This is an option. So you have multiple options. Option one, if you're on this drill,
Mhm.
you can use this
Any
pin.
of those? Okay.
If you've gotten to this one, you can use this one, this one, this one, this one, this one. Throw this out, okay?
Oh, thank you.
Very good. Isaac, you okay?
Yes.
And what number are you up to?
3.2.
Very good. Slow right by. So let me know when you get to 4.1. And are you at 12?
And this, irrigation, so once you
Have you double checked with your
so your irrigation, the water goes through. So you just need that.
Just show you. So
Oh, yeah, it's getting.
Yes.
the angulation. So you're here, 3.2, you grab your yellow, you place it in.
This one, I'm here to produce it.
Oh, you still work. Okay, so then let's go to this one. We'll double check. So it looks a little shallow. We won't go all the way down. Number one, and number two, if you look from a bird's eye view, you look a little buckled. So be sure you're looking at all your dimensions while you're going systematically down, okay? Good, and you're doing okay?
Yes.
Mhm. Yes. Good. Wonderful, folks.
Wow, that's it.
Good, Dr. Bachman, yeah.
You're going slowly, you are increasing, you know, you're going sequentially. From 2.2, you're going to.
Good, in and out.
You don't want to, once you are in a,
Try to blow on the bit. You can blow
When
on.
it gets warm.
Yes.
It's hot.
that's why irrigation is key. So you don't want to remain in there, you're going in and out.
Right. You don't want to make your bone necrotic. Good. Okay, change your bit. Check with your pin, reference that you've drilled to the appropriate level.
Oh, wow, that's cool. You take an X-ray and you're able to see exactly where that is. And from there, you know that. So you're using the central, the group right here. Just make sure you're not outside, you're in between, and that's just perfect. They keep going and continue.
3.7.
Good.
Like I said, this thing's easier than pulling teeth.
And pulling teeth's not really that tricky.
It is not.
It's not that tricky.
Some days I want to give up,
Yeah.
but then I keep going. Like,
Never give up. When you get that little sweat that drips down your back,
Oh my
just keep going, keep going.
it's,
You
I
got
wish it
this.
was down my back.
Yep, I know what you mean.
Oh my gosh.
Yep, so
Yeah,
we went
2.5.
here, 2.5, then 2.8, then 3.2, and 3.7. We're trying to get you here. So keep moving. Mhm.
So you're already at length. with a pilot drill, you're at length, which is 12 millimeters, so you're just going to drill up to length. You can see where 12 is, 12 is, I think, it's just at the end of that top line.
Mhm.
You know, moving forward.
Okay.
So 12 is at the top of the tip line.
There.
Right here. This here.
Yeah.
Yes, that's what the 12 is at.
Where's the one?
So put it at the top of the tick, the first tick line.
Yeah,
Yes,
just
at
the
top.
first,
Yes,
right.
the first one.
Right, okay, there we go. Yes.
You know, you have your patient that's doing a lot of irrigation, and a suction. So you're suctioning. Sometimes if you want to collect the bone, you can actually collect the bone. You take it out, you can collect the bone because autologous, grafting is the best. Company, and you're not spending money, you can actually. Yeah.
Good. That's it. In, out, we're done. We'll go to the next one. Because the more you go in and out with the same drill, you're being around there and you're waiting widen.
Just a little bit, but you want your implant to be a little bit below. Just a little bit, just like 1 millimeter.
Good. How we going?
Yes,
Good. Keep moving.
I think I'm at 4.1 already.
Okay, place your paralleling pin. Good. Double check your depth. Does the paralleling pin go to the same mark?
Yes,
Because don't forget, your paralleling pin is gonna be the same identifiable marks. Is it at the 12, which is this one at the bottom of the double? Okay, let's see. Double check. If it's not, then you want to drill a little bit deeper. It is, good. So next step.
You have to keep your hand, you have to keep your hand straight. And if your hand is, it's kind of tilted. Yeah, so you want to make sure it is straight. Yeah, because it's tilted, there's gonna, it's gonna be coming out at an angle and you don't want that.
Check with your pin.
Use your paralleling pin and take a look and see how.
Good. And we're gonna give Dr. Locken a few more moments. He's gonna get to the 4.1. Meanwhile, on this side, the next step, you checked with your pin.
I like it, measuring, you have to keep doing it, once, if you have
What's up? First of all, this is
a
like
kit that has a stopper,
You see that?
then you
Oh,
don't
yeah.
have to do anything, so it just stops you at
That's not
12
what
points.
we're
This-
Okay.
This is what you understand now what we're looking at and how we use our instruments to make sure that we don't have that kind of deviation. I think it's because you do double drilling with this over and over.
So, just you know, structure up like remove.
And perhaps
What
what
you
we'll
there's
do
no
is I will
bone
place
inside.
one here,
Right.
so you can
Try
see.
to make sure there's no bone inside your structure, so you can actually do something.
You're going to grab your green implant.
What's the last one?
In
1.1.
4.1, so sorry. In your binder, you're going to find a document. Find it first. Okay.
Well, this. Why we.
Is this? It's usually for.
You come out, your irrigation is still on, and make sure your drill is running before you put it in. Don't put it in and turn it on, because it's going to jam and you can't take it out. So you have to be rolling and make sure the water is coming out before you go in.
I will find it.
Because the tendency for you is, okay, you want to put it in before you turn it, you don't just kind of grabs it and you can break it.
Okay.
Yes. So usually there's a little bit of some concavity on the lingual side. If you're not raising the flap, you're not going to see it. Some people have lingual concavity here. You want to make sure that you are kind of parallel and you're waiting from the lungs. You're just going to perforate.
Okay. In your binder, the last pages of your binder, last pages. It's going to be these. You're looking for this paper that says sticker sheet. Yeah, that group of pages, yes, please. You're looking for the one that says sticker sheet. Take your time, it's important. Yes. Keep looking. Not yet. Keep going, Isaac. The reason this is important is if they have a dead body they find in the garbage, the forensic scientists will go and find, oh, this guy had a knee replacement. And then they'll find the serial code of the knee replacement. And they'll say, oh, this is not any longer John Doe. This is Robert Smith, who had a knee replacement at Jacobi Hospital in New York. Now we can identify him. Implants that you place in the mouth all have the same, you have the same responsibility for placing something foreign in the body. You need to be responsible for identifying the serial code. So what I was trying to get with us to is that everybody's going to get their green implant. When you take this sticker off, there's going to be the green sticker itself will separate from the packaging like this. Okay, can you see that, Isaac? And that sticker is going to be your responsibility. Your assistant is going to grab that and throw that in the trash like all the rest of the pieces of paper that you all have. You say, where is the sticker for the implant? This sticker is critical. You cannot just disregard it. It's probably be up top here, just the green. Just the green. Okay, so that is in your chart. You get your sticker, you place the sticker on the paper. I also have two separate ones, one for the consent and one for my progress note. And this is your implant sheet. Your documentation is going to be very critical with regards to making sure you know what implant went into what patient, okay? If Dr. Anarobi says you drilled, you put in a 4, it didn't work, and now you're going to go put in the 5.2, the 5.2 sticker needs to be on the document. And actually, you can take that 4.6, put it back in the package and send it to the implant folks, and they'll send you a new one. Okay. Okay, so now you've got.
And also getting the patient, if you can leave the remaining one of the stickers for the patient so that they know what they have. Because you've added a new body part. Most patients come in and they don't know what implant was. I'm like, I don't know. Yeah, so you need to give them one so that at least if something happens, then they need to go to another doctor. They have something that says the diameter, the length, and the specs of the implant so that somebody else can replace it.
And if you look at the sheet, it'll tell you, okay, what's your tooth number, what's its site, torque, abutment. So we haven't talked about if you're going to do, Dr. Anarobi taught us, you can place an implant, and he said very clearly, you could put a cover screw, which would be a 2-stage implant. Or you can put a healing abutment, which would be a single-stage implant with the abutment attached. Whatever you're doing, make sure you put down on the paperwork so that the next doctor will be able to move to the next step. Okay, so now you got your sticker on. Next step is you're going to open up the implant. Okay, so bear with me. Ready, Dr. Isaac? Doesn't have to be perfect. I love it. Okay, so now we're going to grab the corner. We're going to pick up the implant. The assistant is doing this. They're going to take the implant and they're going to dump it on the table because now the table is sterile and they just touched the implant, right? The immediate next thing that you will do is you'll pick up your implant and you're going to put it in the little well. There's actually an implant well to hold your implant. Okay, so Dr. Isaac, open it. Good. Last but not least, just for the sake of better understanding, is you're going to untwist the green top. Good, you hold the green top. And what do you see inside the green top? No.
Oh, in here? Oh, that's.
Oh, there's a piece in there. Right? Could you kick her green top over? Okay, did you open it, Dr. Isaac? Did you open the green top?
Thank you.
Okay, so all these pieces are critical bits of information. You know, you'd be surprised how many times people say, well, where's the piece? Oh, it's in the top. Okay. All right.
Quick question here. So let's just take a look at this and we'll continue. So just assuming, so right now what we've just done is the assumption that you've made a surgical access. So we went straight to drilling because there's no, I don't know, I think we have from your suturing, tomorrow we're going to do suturing, right? So
Yes.
there's a pink portion where you are, that's the gingiva. So you made your surgical access.
Yes.
So we're not just going straight to drilling. You have to make sure it's either you raise the flap
Mhm.
or you use a tissue punch to make an osteotomy before you start what you've just done. So you have made your surgical access, you drill and you insert the implant, okay? And you go according to the plan. Some implant systems have a round burr before, or a needle, or before the pilot, they have a round burr that you can use to just make, so that you notice here, I notice your implant drill was dancing when you first of all put it, right? You made a mark, but you couldn't stay there, and it was dancing. So if you have a round burr, it creates a little dimple, so that when you put your pilot drill, it stays right there, and you drill. Okay.
What is 1B?
1B is a tissue punch.
Okay, got you.
So this comes for a guided system where you plan it. So you have enough width of the bone.
So there are 3 options to.
Yes, so this one is
surgical
connected
access.
to the handpiece.
Mhm.
This one you can use your hand to take out the
Gotcha.
gingiva.
Mhm.
Okay. And so I'll leave it the next one. So once you make that access, then you will continue just the same way what we're doing right now. So right now we are trying to put we're right here. You've made your osteotomy to 4.1, right? That one we've all done. And you're trying to place the implants. And the implants, like doctor said, you want to make sure you put it in here, and you don't want to turn it upside down, because you want to make sure that the person has something in their mouth to prevent stuff from falling down. So go ahead.
I got a tissue punch
Okay, cool.
and I want to show
Awesome.
you. So the tissue punch is also called a biopsy. Biopsy something. As you get more exposure and more experience, you don't always have to lay a flap. Sometimes you don't even have to remove any gingiva, but a tissue punch is a serrated edge on a circular cylinder, and you place it onto the gingiva, twist, and it will take out just that small circle of gingiva, so that now you can start making your osteotomy. That's what that 1B was.
And it will take it down all the way to the bone.
Oh, to the bone,
Correct.
right there. And so you can see the bone,
Twist it down.
and your implant, you're trying to put a 4
It
point.
has a cutter in it?
Yes, so it's actually cut. That edge there, once you
Be
take
careful,
it down
don't
and turn it,
put your finger
it's very
on the
sharp.
edge. I'm gonna go get a model out of the car that has gingiva so we can make some holes.
So this is for flapless. So it's either you do razor flap or you go flapless. When you go flapless, you should have kind of planned it and be sure that you are inside. I have some patients that are like very
Like
wide
in
bone.
a edentulous spot, that'd be perfect. Okay.
Yes. So you're sure, but if the patient doesn't have, if you're not sure, if you're, the flap, raising the flap, this is a typical thing of what you do. Local infiltration, you would have given some antibiotics. I usually give 2 grams. Yes, every patient gets 2 grams of antibiotics before 1 hour before. And they continue the antibiotics after you want to make sure they are covered in that way.
All right.
Then in local infiltration, just follow this. This is a typical way to
That is a pan.
Yes, calm down, everything you need to do. After you finish, you even give them some prednisolone to stop the sweat. You just make sure there's no swelling, no pain, nothing at all. So you raise a flap, right? So you can measure the width, because it's all about measuring. If you're going to do it freehand, you want to be sure if you don't measure it, you wouldn't know what you're working with. And you just have to have a sense of where you are. Then you can plan, you're going to be at the center. And once you finish placing your pilot drill like you did, you put that the guide pin there. Yes, perfect.
Edentulous space. You have your Minnesota out, you place it right into the spot. You're gonna twist.
Nice. How much does this cost?
They're nothing.
Oh,
They're used for biopsy. It's a biopsy punch. If the person has a fibroma on their lip, you place it on twist, and now you just take a plug of tissue out
Like that,
and send the specimen to the pathologist, but this is very useful and helpful for when we're doing an osteotomy. Good point, Dr.
Good, good, good. Well, this is like pretty cool. If you have that, easy to do. Like I said, once you have done all that, your paralleling paint is very important. Like we've been doing the out here. I just want to show you what you've just done. So you want to be sure that this is your pilot drill, so you've not gone very far. For the pilot drill, I like going to like 6 millimeters. So I don't go all the way to length, just in case I need to change the angle. So this tells me, well, I'm in the right place, I planned it well, and I can now continue. So you continue to drill, you now drill sequentially. This is where we are right now with what you've done. So you've drilled up to 4.8. And so for this, it's called two-stage. There are two-stage types. There are two types of drilling. Is that you do a one stage or a two-stage. A two-stage is when you use what's in your green cap. Your green cap has a cover screw. So if you're going to put a cover screw, I'll show you. That means you're going to close it up. But if it's one stage, you're going to put a healing abutment. That way you're not going back. Once you take the healing abutment, you are ready to restore. But for this, we're going to use a cover screw, which is on the head. So let's continue.
Okay, so everyone get your handpiece. Okay, you're going to look very carefully at the lower level, these two lower levels. Okay, one's going to say ratchet, and one's going to say handpiece. Ratchet, handpiece. Okay, handpiece, this handpiece. You're looking for the blue-green because you put a blue-green implant in. This is blue-green implant for your handpiece, and you'll see that it has a little nick. Can you see that? On your handpiece? This is going to go into the handpiece. So you push in the back, put in the handpiece driver, versus if you pulled out the blue-green and it has a square back, that goes into the ratchet. Okay. Now, the driver is going to be blue-green. One more time. Absolutely. Absolutely.
So there is the implant driver. The implant is carried, the implant that you have here can be placed into the osteotomy you just made by using the handpiece or using a ratchet.
Right.
And one of the you have two carriers. One uses the handpiece and one uses the ratchet. So you have to pick the right one. Sometimes you place the implant using a ratchet because it's just convenient for you to do that.
Okay.
And once you're using the handpiece, you have to change the set because you have to change. It has to be like 45 RPM. So press implant, please.
Next, you're going to engage your implant.
35.
Yes.
Engage your driver into your implant.
So you want to make sure that you bring it down. You have to guide. You don't want to make the mistake of trying to put the handpiece. Placing the implant at 1,200. That is.
So I've seen the handpiece, and then the surgeon goes back with the ratchet.
Yes, you have.
Yes.
Yeah. Okay.
So they start with that. He doesn't go in all the way.
So I didn't know what it was,
Yes.
but now that I'm here, I know what that means.
Your driver
Okay.
is going to engage into your implant.
Okay.
Push it all the way down. Sometimes I even twist a little bit till I hear it engage, and then it should pick up my implant. Because you don't want to touch the surface of the implant in any way. That you just did, right? Okay, so now it's engaged. Hold it like this. Good. Hold it always up like this. Okay.
So let's do that again. Sorry, I just want to try it.
Next, you're going to put yours to your implant setting.
Pick it out.
Push,
Pick it out.
push. Good. Bring it up to let's say 35. Good. Okay.
Wasn't it?
Here, turn it upside down.
You want to make sure it's upside down.
Is it a little trouble?
That way.
Trying to see what.
Because you can drop it. Once it doesn't click, you can drop, but you want to make sure that the patient has some kind of,
Yeah,
you know,
it's fine.
gauze in their mouth to stop it from going down the throat.
Great.
So you want to make sure that you're trying to put it in
Always
here.
keep it
Upside.
Okay, I'll hand that to
That's the
you.
best way to carry it.
This, you
You
push
go to,
this for
and then
placement.
for
Is that-
this
push
setting,
this for
there's really
placement.
no water.
Right,
Once you are
yours is at
placing
70, bring it down to 35.
For implant placement, I think it goes by the setting here.
Yeah,
There's no
but
water.
it should be on the one with the implant.
Yes, that's the
Okay,
one,
okay.
yes.
And now, this hand is gonna hold on to the mandible,
Mhm.
and you're gonna turn it over gently towards your implant osteotomy. Good, and hold a little, there you go.
Put it in
Put your
there.
foot on the pedal. Good. You too. Put your foot on the.
Like,
So now this is in the throat. So come from over here.
yeah. Yeah, very slowly. Take it easy.
Good.
And
very
you notice
slowly.
if it's too tight, the implant, the motor is gonna stop.
Yeah, it is gone.
Good, very slowly, right?
Mhm.
Right, so that setting is very important.
So
If
it's-
you start
Yeah.
working on
Going
it, good.
deeper.
It's moving.
Yeah, it's supposed to go in.
If
it's
it
supposed to-
isn't going
It's
deeper,
stuck.
this is when you take it off and attach.
You notice
your-
there's
Right.
this implant is it's a gum level implant.
No.
So it's not just it's not a bone level. So the silver portion,
To put
the
your
top
finger-
silver portion should be flush with the bone.
So it's,
That's the bottom silver
Next.
portion.
grab your ratchet
So if
driver
it's not going in, you wanna take it out?
and your
reverse it?
ratchet.
So you can go reverse.
So
You don't have to reverse anything. Don't reverse anything.
Okay.
Disconnect, find your ratchet, which is
Uh-huh.
already set up.
Okay.
I want to tell everyone this. Yours is in, right?
Flush.
Look at your ratchet.
You're ending.
It's going to have
You
it,
see where the-
Where the line there, so.
Yes, bottom.
means
silver
you're
line
going
is
down.
Where you're supposed to be.
Twist it up. Arrow down means you're taking it
Out.
out. Okay, so look at your ratchet. Look it up. You see the ratchet has an arrow. If the arrow is facing up,
Mhm.
you're placing your implant down. Can you see the arrow?
Oh, yeah, I see it, yeah.
Okay.
So should we?
Very
facing that?
carefully. Look very carefully. Can you see that arrow?
Mhm.
If the arrow is up, then you're placing your implant down. If your arrow is down, you're taking your implant out, okay? So
like
this needs to be onto your,
Go this way, they're gonna be taking.
okay?
Mhm.
And now you
Engage
engage it,
the tightening.
Mhm.
good, engage it. Put your finger on top of your
And if you
ratchet
sit down, you
Yes,
lose
yeah.
and
So
twist
you-
it down in there.
Just like a wrench,
Got it?
a wrench.
That's why you didn't have to back anything out. We're trying to put implants in.
Okay.
Put your finger
So
on,
then it should be
So that-
facing down like there.
You're trying to take it out if you do that way.
right, steady, steady. Good position, perfect position.
Beautiful.
You got it?
Yes.
It's going down.
Goes back and
Yes.
Good.
pushes in.
Good, all the way down. Crank it down till it's flush to the bone.
Good. See, you can feel it stick.
Yeah.
Then you go, that takes it in. So if you have not done your osteotomy to be the size of the implant, you're gonna have a problem with it. So you have to be, so this is gonna show you whether did you drill to depth or did you drill to the right diameter? Obviously, we got to 4.1, but did you drill to 12? Good. I think you're in. So this one has like a silver portion, so I think it's
It does, but I want you to crank it all the way down.
Oh,
Yep, till it's flush to the bone. It has a silver portion, but we subcrest
mhm.
and make sure your mandible is parallel to the bone. You get comfortable.
That is moving.
It's moving.
Good,
Well,
all the way
that jaw's
down.
Broken.
Good, get it down.
Okay, the bone portion of things, no problem.
And this will show you if you're right in the right center. If you were to buckle, just like a stake in the ground. If you ratchet this down and your bone splits, you were not in the right spot. So that's why we're practicing on the model in the room with some plastic.
Very good.
Good, keep going.
That-
Let me show you, let me show you.
And you go on this, you have
It's
the
an upper body workout.
It is, oral surgery is physical activity. This is too short.
we-
Can you put it in here first? Yeah, well, engage it here. Okay. Yeah, you can put that in here.
How's it going?
Good, you put your finger on.
So is it tilted a little bit?
This is coming.
Right, I can see, it, but it's okay. Yeah, in there.
Mhm.
Wash, that's it. That is perfect. You're ready to
Maybe you
make
would-
money.
So we have to take it out and go back in.
What was it in there? It's under prep. This is the first one you ever did, no problem.
Okay.
But clearly in the future,
Make
I
sure.
don't want to force it.
Right.
Okay, so I'm not sure where the pin is. Pin's still here. Can you put the pin in?
Usually when you're doing this, you don't want to do this.
Okay.
Because in the mouth, you can't really, so zoom in right
So
down.
put the.
From the
put
control
the-
side. Yeah, so you have to put
Put
your thumb on the
put
top.
this on
Put your
the
thumb,
pin.
this thumb.
Good.
on top.
Now, next step is you're looking for this says driver. Isaac, how are you? Is it flush, Isaac? See this says driver here, Doc?
Yes.
Pull the driver out, pull this driver out with your finger. Good, and yours is flush. Good, you got it. Oh,
Well,
and you
check it
got
out.
to the next step. Good,
So for this other place, you use your hand and.
good. You got driver,
to-
grab your
to-
cap. Unscrew
if you're
cover
looking at the
screw.
arrow.
No,
So
no. So
tools.
grab your green
So if it's.
Uh-huh.
and take
You
your.
notice this, you listen to the, once it can go back, I mean. it's
Good,
not
all the way
really
out.
forced that on. But if it goes, yeah.
Good, and bring your cover screw over to your implant.
Take it out.
So if it's
Good.
towards you.
Take it all the way out.
Yes.
It's lefty loosey.
Oh,
There
okay.
you go.
And away
The way, it's, you know, we can turn it upside down, that means you're trying to
loosen.
loosen it to take it.
Good, put your cover screw on, right? Everybody makes sense now?
Right.
And that's just going straight at it. You see, if we had you over here making it flap and all the gingiva, we'd still be working on the gingiva.
Yeah.
So this is just going straight at it. Okay, so you can get right to placing the implant. Now, guess what? I want you to take that implant out
Yeah.
and you're gonna put it on the other side. So take the cover screw off first, back your implant out. You can use your ratchet. Start with your osteotomies on the distal. And we're gonna do another one, okay?
You put it back in.
And that's the implant placement. In a few minutes, we're gonna have Dr. Anderobi go over all the parts and pieces for the restorative parts. And by the way, Donna, I have all of them.
Mhm.
I want to talk about these pieces. This is his territory. I am a novice at that. Okay, how are you doing? You taking it out?
Yes, so for
Good.
this, if.
It might be tricky for you because this is so solid. Let me see how we can, where's the ratchet piece? This one. And where's the actual piece that goes in? Or is it underneath? Try to figure this out.
This is fun.
The only reason why I'm taking it out is because I don't want you to use a new implant.
Okay.
It wasn't that hard to take it out, actually. You wanna do it?
Yeah.
How are you guys? You taking it out?
Yes.
How are you, Dr. Bachman?
So am I going counterclockwise?
Let's take it out. Right?
Yeah.
Yes, once you hear crank and it's coming out, you put this,
Also,
once take it out.
I have all the impression material.
Okay,
which
sure.
ones, and it's just,
I think going deep.
Now this is taking it in, this is going in, so out is gonna be this one,
Oh.
out, yes. Yes, so you pushes it, so you're taking it out, so you gotta hold it. Yes. That's it. Implant. So sometimes when you're placing your implants, you can actually, if it didn't go in all the way, because some of these implants are self-cutting. So you can back it out. If you're sure you drilled to the right diameter, and the right length, and it doesn't go in when you use your machine. You can back it out, then just back it out for like 3 turns, and then go back in because the implant itself is self-cutting, so it's going to go in. So we're going to afterwards we're going to create another osteotomy. But while once we finish placing, then we'll talk about. I'm just going to go through this. This is your typical example of your drill bit kit. You have a kit that has a couple of drills, just like what you have in front of you, different diameters. This system, but it's MSDI. This system has a stopper, so you cannot drill further than you plan.
It's not all.
Yeah, good. Yes,
There's a.
that's it. So you want to make sure it's rolling before it touches the bone. So you don't want to put it on the bone and. So are they going to go ahead and make another osteotomy for this? Okay, let's go ahead and do that.
We're gonna go this side.
Okay.
Then you gotta start with your pilot. Dr. Arnold said that after you use every instrument, make sure you put it down. You take this apart so you know which pieces go where.
Clean it out so we can see. That way you're doing.
Good.
So you see you already have made a mark. Is that where you want it to be, or is it shifted a little bit? What do you think?
I'll shift it.
So that's fine. So
Good.
that way
Here's
you're not
one.
going too far.
So I could go in middle mark.
Okay.
So
It
if
might
you
be
go
a
before,
little
you can
even
stop and get it.
tricky because it's on the
You just have
side,
to hold it
but
tight.
that's what you're gonna do. Okay, and this one's gonna be perfect, a little deeper this time, right?
Yes.
Because it was a little stiff.
Where is the,
It's gonna be on this page.
let's see where the.
That one,
Oh, this one,
yes. Page 19,
okay.
good. And yours worked out, Dr. Hawkins?
Yes.
All right, excellent. So this time you're working on this side, this little finger is gonna hold on to this piece so it doesn't spin around. Got it?
You good? So you really have to check all the time when you finish, just like the way you put your slow speed slow speed drill. You want to make sure that the drill bit is on there secure. Good. Nice. So you're coming from behind. Usually you won't be able to do that if you're working with a patient because that's the patient's truth, right?
Yeah.
So you want to make sure that you are, so that you change it, something, that's the only way, if not.
Yep, you're doing good, right? Because the patient's feet are out there. Good. Good.
Your finger rest is important so that you can have a control of the drill bits. If not, you're just gonna shake and dance and like that. This hand is controlling it. Okay. Your implants, is treated, say titanium that is either plasma or some kind of treatment done on the implant. I want to make sure that all the treated portion is within bone. That is what you're trying to do. So you don't want any of that portion showing through. What's the speed you're at?
1.25.
Okay. It's kind of, I don't know, maybe you're stepping slowly on it, right?
So is that slow?
Yeah, I thought you.
I thought I was going fast.
Okay.
I'm thinking, oh, he's saying that I'm going too fast.
No.
But
In and
one
out.
thing that he will tell you is you're coming from the throat.
Yes.
Okay,
So,
yes.
Yes.
Yeah.
Well, the patient's mouth is open and they are trying to.
Good.
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 So with a surgical guide, you can put a guide on top of it and you prep through. So it helps you keep your hand still. You want to make sure your hand is not dancing and you're going back to the same.
We're still doing the same.
Yeah, the same implants diameter.
I'll talk a little bit while you're working. So if I have Dr. Anarobi and I are learning how to ride a bicycle. Dr. Anarobi's bicycle has 2 wheels and training wheels. And my bicycle just has the 2 bicycle wheels. And the instructor says, okay, folks, everyone get on your bicycle. Dr. Anarobi jumps on real good. I get on, but I'm a little wobbly because I don't know my balance well. I'm trying to keep both feet solid on the ground and hold on to the steering wheel, but I haven't even tried to put my feet on the pedal yet because I'm nervous that I'm going to fall over with my bike. Meanwhile, he's got both feet on his pedals and he's holding his handlebars. The instructor says, Dr. Jackson, why are you taking so long? What are you doing? I said, well, I don't know where my footing is. I'm trying my best, but I'm still hobbling along on trying to get on the seat. Meanwhile, Dr. Anarobi is practically all the way down the road. Okay, so he's flying high. His hair is blowing in the wind. He feels the momentum of the bicycle. He feels great. I'm still straddling this bicycle, and finally I get one foot on the pedal. I get another foot on the pedal, and I've just now gotten my momentum. I can hold on steady to my handlebars, but still I don't want to hurt myself when my knees hit the handlebars. I'm still conscientious about all of my surroundings and all of the things that are going on. Guess what? Dr. Anarobi hits a rock. His left training wheel totally falls off. He has no idea what it took to get that momentum to start with. Meanwhile, now I'm over here riding like I know what I'm doing. And I will never, ever need training wheels, right? Because I got the understanding of how do you do this and how do you figure out your own balance? How do you make sure your knees don't hit the bars? He, on the other hand, is standing on the curb crying because he can't even figure out how he's going to get back on that bicycle. He's not a slow guy. He's going to figure it out after a while. But lo and behold, the second wheel falls off and he's completely at a point of no return. That's the difference in my mind between a surgical guide and me and Dr. Omi trying to tell you how to do this so that it might be rough in the beginning. Your angulation may be completely off. You're not sure how deep to go, but best believe the wind will be blowing in your hair any minute now. Looking good.
I think I went through the
A little bit.
still a little bit. Oh no, no.
No, it's not.
No.
It's really good.
You think it's angled? It shouldn't be more buckled?
I mean, I think it's okay.
As long as it's in the
It's a little
bone.
bit close, a little bit close this way, but that's what happens. So that's why I noticed once because the initial thing you did, you went away a little bit.
Yeah.
Yeah, but that's fine. Okay, that's fine. So far, you're still within bone, you didn't separate in the skin. So you have your implants in. Once you finish placing your implants, the patient comes back. If you did the one stage, you're going to bring the patient back to take the cover screw away and put a healing abutment. When the healing abutment is on there, after a couple of weeks, you want to bring the patient back and take an impression. But you're trying to put a crown. If after 3 months your implant is in there, you want to take an impression. So once you finish placing this implant, we're going to do that. We're going to put an impression coping. The impression coping could either be an open tray or closed tray. And we'll see when you want to do that. So this is an example of an impression coping, which is on the screen.
That is usually after 3 to 4 months.
Yes. So at least, especially if it's soft bone and you didn't have primary stability, you probably want to allow it to heal for a longer period. But 3 months should be fine for the standard, something that was done properly.
Dr. Anarobi, can you find the healing abutment?
Yes, right here.
For the soft bones, how long would you leave, like 6 months?
Yes.
And that's what I tell the patients to come in for a checkup after 3 months, and then I'll see you in 6 months.
So I have this is an impression coping right here.
Here.
You're used to restoring implants now, right?
Yes,
Okay.
so I've done skin body
Scan, powerful.
and I've
Powerful.
done, and I usually lazy Zimmer, healing abutment.
You can scan that too,
Yeah,
right?
yeah.
That is good. So with Zimmer, you can so this on the
Oh,
screen.
no.
When you finish placing your implant, we'll go to placing your healing
Turn all
abutment
the
on
way
there.
to the appropriate depth and length,
With a 4.1.
good, and you,
Is it going in?
and you.
I
are
believe
now
so.
gonna
So
change
with
your
this
motor.
one,
Oh, yeah, so you.
does it have water
Yes.
also?
No water. So you have to make sure, but one thing that you're sure it's bleeding. It has to be bleeding. Because if your osteotomy is not bleeding, that's a problem because you need clotting for osseointegration to take place. Blood has to be involved, clotting then.
So that's for
Okay,
the
then you
ratchet.
can use your ratchet now to tighten it.
Yes.
Pull it all the way out, pull it up, out,
Okay.
strength, there we go.
That's so.
Yeah,
Engage
this
it
one
in
is-
peace, in peace. Yes, sir. Good, take your time.
I'm gonna put on counter or clockwise.
And then engage it into your
Clockwise. So the arrow should be facing you.
If it's getting
No,
a little
you're right.
Yeah, arrow up. If it's not, if it's arrow down, then you're taking it out. Try to put it in. Have you changed the setting?
Yes.
Okay.
good,
You
good.
never forget to change the setting before you place the implant.
Good, I'll take the cylinder. Excellent. Keep your finger on the piece so it doesn't spin out for you. Yep. Good. This finger here, yes. Good.
Way to go. Look at you, cranking it out.
Yeah. One pedal. Pedal to the metal.
That's it.
Don't hold back. Good. Isaac, bring your patient's chin up. Parallel to the middle. Up. Chin up. Parallel to the floor. There we go.
So
Good.
Yeah, I got
Take
it.
that off.
All right, so it's
Here.
in,
Good.
and
I
then now
usually
we're going
stick it
to.
In this way so I can
The
see
healing cabinet.
Yeah, but
That's
you're gonna put the.
Now attach your ratchet. Make sure you're looking for
Oh, you
your
want the
arrow.
impression coat in
up.
there. Okay.
So with this.
You can use the driver to. You can put your hand initially, but
Yeah.
no, this right.
Oh.
Just
There we
tighten
go.
it a little bit.
Mhm.
So after
Good.
placing
This is
that,
why we're learning. That's not right.
Oh.
So take it out.
And then you
Yep.
scan.
Yep.
yeah,
feel
you
better.
scan or you take an impression.
Good.
I assume
sure
so.
the
If you have
handle is
a scan body,
Out of the mouth,
you just scan.
not
So
down
I
the
don't
throat.
know how to do open tray, closed tray. I've heard.
We're gonna
just
teach
can.
it today.
You
This
just
is what
can.
it's all
Yeah.
about. Good. To put your, yes, sir. Yes. Good.
There's a
So this finger is gonna go here and this finger is gonna go here. Got it? Feel comfortable like that?
Yeah.
Okay, and make sure the little piece doesn't move.
Mhm.
Good.
So this is your impression coping. You have one in front of you. There's a green one I just put.
The one you,
Did he? Oh, you
no,
dropped.
no, this is.
Okay, good.
So what do you add to your petri dish before your bone starts to die?
Nothing really. Blood. I mean, just blood from So you use blood or use some saline
Okay. So just
to
a-
reconstitute. If you're using bone, but if you're using the patient's bone, it usually
Yeah.
comes together quickly and you use that. But the patient's bone is usually the best, so you're not spending more money to do that. So you have your impression coping in to this. This is your healing abutment.
We put this back in.
No, you can use your impression coping.
I'm so surprised.
So this patient came in, implant were placed. So we took out. Patient came in after a couple
Better?
months with healing abutments. So we took out the healing abutment and we placed impression coping. So this is because this is a multiple implants that were placed. So you place the if scanning is good because you don't have to spend material buying a tray using any other whatever like impression tray or impression. But sometimes for this case we use an open. Open means you're making a hole on the tray to be able to take the impression. Sometimes you do that, especially if the angulation, when you're doing multiple implants, you want to just see how it comes out. So you're forced to do that. So this is the patient had an healing abutment in, then you took it out and you placed impression copings, which you've done. And if you have a tray, are we doing that after we come back from lunch?
Yes.
Okay. So you go you take impressions here. We'll see. We have managed to.
Is it engaged? Because this mine is not fitting.
It's green.
The driver screws it in.
So it's the top of this portion turns in.
Okay.
So once it's green, it sits in a certain way. Then you can tighten the top. You can actually use the driver too. Right here, screwdriver that carries to tighten that portion of it. So once you do that, you take an X-ray because you want to make sure that this is seated properly. If you don't sit it properly before you take your impression, then your crown is not going to fit. If it's not seated all the way flush with the level of the implant, if you don't have that, then once you if you take impression like that, your crown is going to be too tall. When you put it down, like, whoa, what's going on here? That's 1500 gone down. So if you're doing multiple implants, we kind of advise that you join the impression copings together with some raising.
So that's where they do the floss
and your DC pattern raising comes in to tie together, just to be sure. So when you finish taking impression, it doesn't move inside. So you want to make sure that what you have in your mouth is what is happening in the lab. Because you don't want the lab to have your impression, it moves, they'll make you a crown, you put it in the mouth and it doesn't fit. Yes, doctor.
Can you find the healing abutment?
Yes, the healing abutment I've given you. So we'll take
good.
okay, so we can so you place a cover screw, right? You use your cover screw, you use your healing abutment.
The cover screw was in the cap.
In the cap.
Yeah.
Okay. Because it looked like you were like, what cover screw? The cover screw is in the cap. That, like Dr. Honorable said, if it's a 2-stage implant, you'll place your cover screw, which is in here. If it's a 1-stage implant, meaning that you have very good stability, you feel like this is good to go, you're going to put your healing abutment. A healing abutment is used for gingival contour. So for the 4 to 6 months that you're waiting for it to integrate, the healing abutment will allow for the gingiva to come up to the gums. If you please place your healing abutments on all of your implants. Right now, BioHorizon has what they call anatomical healing abutment, which is not the cylindrical one you have in your hand, but it actually gives a better contour of the gingiva. And if I'm not mistaken, it's a scan body. So you don't have to remove it to take your impressions. Remember, when we go to the lab, we're teaching you analog, what Dr. Anarobi is talking about. Analog is all this about impressions. But in 2025, not taking impressions as much, we're doing intraoral scanning. So you're going to learn here at International Implant Institute how to do it, let's just say old school, because that's probably where you're still at in your practice. But eventually one day, when you blossom, you will be doing intraoral scanning. And Dr. Oku, are you doing intraoral scanning?
Yes, that's what she does. It's a scan bodies.
I heard you say scan body.
Healing. Can I-
Yes, that's a hit. So that's the hit.
But it was a healing
Abutment.
abutment with the code on there.
Yeah, so it scans it.
Yeah.
So you're gonna take out your impression copy and put your healing abutment. Then once you get done, I'm gonna give you a temporary, that's what, we have the lab guy coming today.
At 4.
We're gonna make, if you're gonna make a temporary crown. And so you have a temporary abutment. So you're gonna, once you take out your healing abutment, I'll get you a temporary abutment.
Abutment on yet? Healing abutment with your driver. I just want to see you screw it down in place. And now let's say you did have, you did raise a flap. Well, now you're gonna suture around your healing abutment. Or if you did your punch, it's gonna be your healing abutment just peeking through.
And it'll cover up.
You'll cover up with tissues. Making sense? Good. And Dr. Isaac, making sense?
Yeah.
So the healing abutment helps you with that emergence profile. So the anatomic one that the BioHorizon has is just so good because it gives you the width of the crown they're going to place in there, so that once you're putting a crown, it just fits in really nicely. So it's a really good one to have. So let me get you a temporary abutment. With these implants, it has a hex. The implant has an internal hex. It goes in, so this all the things that you put in kind of fits into that hex, and it tightens. It kind of sits in a certain way. If it doesn't sit, then you shouldn't screw it in. You should make sure it sits and it's flush. Okay. It has an abutment screw inside. Each abutment has a screw inside. So let me hand this over to you. Sometimes you don't have to deal with all of this because the lab makes you a crown and everything is inside. You just put it in and you're gone. But you might get to a point where, especially if you are working on a front tooth, you want to give the patient a tooth before they leave. I mean, and you can charge for a temporary crown. Some people will say, "Oh, if I'm going to pay, no need." But if it's front teeth, people don't like going, especially if you're doing an immediate implant. So this is a temporary abutment. So with the temporary abutment, you can actually, if you do this in the lab, that means you can shape it because it's usually longer than your tooth. So you can shape it like you're making a crown prep. You can actually reduce the height of your temporary abutment because you are trying to fit. Let's imagine we have this. Okay. So today we're going to place, somebody's going to place an implant here, okay, and we're going to put a temporary abutment on it, and Julio is going to use composite and make you a temporary crown, so I will see exactly what it takes, so maybe
I'll
want to do that. Yeah,
sure.
So that's your temporary abutment. So you want to shape it, you want to reduce the height of it. Then you put some composite around it, and you have a tooth there, and you're done. So you can actually, if you are into that.
So composite will bond to this.
Yes. So if you want to do that, if you had a wax up, if you do the wax up, let me use the one.
Yes.
So if you put a tooth here and you have a wax up, right, and you do a suck down, I think you're trying to make it a bleaching tray. You can now take the bleaching tray and put it over that place, and it takes, so you have an impression of the crown. So this is going to be at the center, so this can form. You can actually put some acrylic and put it out there, and your crown is ready. So far it binds to the, but we'll do it today, and we'll go from there. Okay, right.
All right, so you've placed the cover screw, you've placed a healing abutment, you've placed your impression coping. Okay, so bear with me. I'm gonna place implant in the maxilla. And then you kind of see how I'll be just as particular with the orientation of the nuts of the model.
You have to take this out. You put your September. You use this right there. There are so many small parts, so it's better to pack the throat when you're doing all this. You have to put a throat pack in there because these things can, the first time you're doing these things, everything just seems to be all over the place. So you want to make sure once you are taking the instrument out, the implant out of of this, you want to turn your hand upside down. You want to cut it like this. When you pick up the implant, you're gonna turn your hand piece like this because I've seen it fall several times. So you want to make sure you avoid that. That usually happens. So once you finish taking that, the lab can get you. This is a temporary prosthesis to just be sure that we have the right occlusion. Patient was able to rock this for a couple of weeks to be sure the occlusion was right. And he has a high smile line. That means we're going to paint this portion with some pink porcelain.
And I'll take your handpiece, place it onto the 1-1. Okay. So I'm gonna place a maxillary implant. I'm gonna do this, make sure it's 1.25. Push it to 20 to 1. Yeah, that good. Okay. I always check my through. Okay. Just as you would. This is a maxillary, so that's why it's tipped up in the air. When you're working on the maxilla, you want the patient all the way back. You should be able to see every tooth. Okay, if their chin is not, they should be in the sniffing position. And then you don't have to hold on to the mandible. You're working on the maxilla. So this person's chin is completely up in the air. I'm going to be starting to place my implant. I'm going to be placing it more palatal than buccal. I'm also looking at the angulation of the adjacent teeth so that I'm still in the same angulation.
And the access is going to be on the cingulum area. So so if you just imagine where the access will be, you don't want to be too facial. You don't want to get into the buccal bone. The buccal bone for these cases have to be preserved. You got to stay away from your graft. You have to graft it when you're done.
Just in, out. That was it.
So this is the case here. So we put a pink porcelain on it, and this is screw retained. So crowns could either be cement retained or screw retained. Screw retained means the access is, you can still get to the access. But if you place the implant wrongly, that means you have to use a cement retain. That means you can't get to it. You have to cement it to close. If you were not put right, in order to, because you don't want to make the access coming, the color is going to be different. Patient won't like it. So you have to use a cement retain crown. So you have to cement the whole thing. Yeah.
So in the maxilla, it seems like you would rather have everything a little bit palatal.
Yes.
Yes.
To preserve your buccal bone, to make sure the access is just in the cingulum area, so that you can. Cement retain is the way to go. Screw retain, because cement causes periimplantitis.
Right.
You have to avoid that. You got to plan in such a way that you can have everything together. You don't need any cement. Because if you do cement retain, you just have to make sure that you go in and clean it out, take X-ray, and be sure.
And then I'll get to 3.2. I'm only going to place a 3.8 in there. So I'm still along the same long axis of the adjacent and anterior incisor. And I go in, I go down, and I'm coming up. That's it. Maybe one more, but really just coming right back up, in, down. And now I'm at 3.7. I'll put 3.7 because we're putting a 3.8 in.
Every time you want to place, make sure you do some evaluation of the restorative space.
I can double.
For this
check
patient, I know the
here.
central,
Angulation.
this tooth is going to be like 7 millimeters. But by the time I look at it, it's a little wider.
Yeah.
That means if you put a tooth there, it's not going to look natural. The patient has to be aware. It's either they're going to
Yeah,
get some.
that's a little
or you
different
need to do
than
something.
straight up and down, so I want it to be.
Yeah, so you need to calculate the space and be sure that you can put a tooth there that'll be
It's
aesthetically pleasing.
But also, what I'm looking at is this incisor, so I want it to be diagonal to the axis. I'm gonna pass it around. That's no guide utilizing adjacent teeth and anatomical landmarks as your boundaries. Dr. Honorable, do you want me to keep going or do you want to go?
I just want to show
Sure.
just what we're going to do today. So patient comes in, we had a discussion about restorative space. She had finished ortho and the session was going, and I just let them know that, you know, the tooth might be a little wider than adjacent lateral. I was missing, and patient was supposed to be okay. I have to make sure. So this is what we use. So this is a long impression. This is, you have one here. I'll show you. Let me give you an open impression. You can take out your folders. That is an open impression coping. It means for you to take it, you have to make a hole in the tray because it's too long. And sometimes you do that just to be able to, you do that for multiple reasons. No, but a closed one works as well. So that you can take out your, your temporary abutments. So you've done 2 impression copings today. One was open and one was closed. And right now you have the open one with you. When we come in the afternoon, we will show you. But this is exactly what we're doing. We're going to, so you place the impression tray in there. This is analog way of doing things. We're not like Dr. Folo. Dr. Folo doesn't have time for analog stuff. She's like, I want to just scan and go.
Didn't learn.
So
So I
that's
have
the-
a scanner.
It's a
like
good thing. It's because it's faster. It gets, you can just email it to the lab that same day. You're not going to spend money on tray. You're not thinking about things warping or changing. Scanning is the best way to go. But you know, this is this is what we're going to do. When we get to. This is what we're going to do when we get to Accra. You know, we're going to get light body, heavy body. You're going to syringe the light body around the impression coping. Then you put the heavy body on the tray, and you will just take that impression, and it's going to come out like this. And this is one more thing. This is called what? An implant analog. This is a lab implant. So you're going to connect. Do we have a lab implant here?
That stays in the impression.
Yes. I don't think we have it here. I think we have that one here.
Implant, system was going to implant replica.
Yes, it's an implant replica. It's like a lab implant. So you connect the impression coping with the lab analog. So right now the impression coping, this impression coping is inside the implant, inside the impression tray. So you now connect the lab analog to it. Then you take the impression such that this now represents your implant. Now, once you take up a cast, it's going to look like what you have there. So that is an open, you have to make a hole on the tray. See.
I've seen them before. So you make an opening on the tray so that you can,
Yeah, so you have to loosen it to come out.
Yeah.
For the closed impression tray, you just snap it out.
okay.
For the closed one, you're not going to see that hole. It's going to be covered by the tray. So it's like closed, and you just snap it out, but you still have to loosen it. But for this, you won't be able to take the impression tray out without, you have to loosen it first. We'll try some of that. One of the things that so this is an example of having taken the impression. So if you connect the analog here, that's what you have. One of the easiest thing to start with is somebody who needs a denture and he needs 2 implants, especially on the mandible. So you need for that, that means you place the implant and you're trying to place 2 locators, like what you have. Just take a look at it. Start here. So that's a locator abutment for 2 implants over denture. That's the first place to start. If your first case should be this, you are placing 2 implants, so you're going to charge for the denture, you're going to charge for just placing the implant on. Okay. I'll show you.
And that person's probably already a dentulous, so this is not difficult. You may decide to use your punch, and you make a punch at 28 and 21, so you can see your inferior nerve. And now you're going to hold your mandible parallel to the floor. You drill in your 28 site all the way to just short of when you're going to place your implant, put your paralleling pin so it's sticking up. Now you're going to start with your osteotomy in, let's say, site number 21. And you can use that 28 as a reference so that you can see that they're both looking straight up and down like 6 o'clock. And then you put your implant in at 21, then you put your implant in at 28 and put a healing abutment on. Or if you want cover screws, let them settle in and get comfortable. And then eventually you can engage your denture into the locators onto the denture attachments.
So the patient has a lower denture. It's never going to fit because it doesn't have enough bone. So standard of care is 2 implants. You could start with that. Somebody who has a denture that doesn't work, so you just get 2 implants, you place it. I'm giving you a locator abutment, right? So that's what this is. So you screw it to the implant. So this is your locator. It looks silver here, but it's usually like gold, yellow in color. So you put 2 implants there, and so it has inserts.
Oh, the blue and the yellow.
Yes.
I mean the white. Okay.
So let me show you what this inserts.
It will insert into the denture and give the patient, let's say it's an elderly lady who needs to be able to take it off easy. Or maybe it's a young guy who lost all his teeth early. He has more muscle strength. You want to see how well it can hold on to your implants. Depending on which ring you use will determine how much force is necessary for that person to take the denture off.
This is an example of what we're talking about.
Exactly.
So that's your implant. So this inserts, I just gave you the blue.
Right.
There, it's inside the denture.
Okay.
Right. So this one uses a ring. This uses a different type of insert, but it's pretty much the same. But
So you change these rings?
every 6 months or as long as it gets loose. So 6 months once a year, you change your rings. So for this one, you use rings and it snaps in. 4 implants. So you're charging for the implants and you're charging for this, and the patient is good to go. It's cheaper than doing a fix. It's a lot cheaper. Fix is going to cost you maybe like $10,000. For this, you can charge for like $5,000.
Or blacks. Dr. Arnold, do you know the strength of each of the colors is black, less strong?
Yes, the black is the default. So black is the lightest. It comes to the insert. If you pick up the insert, where's the insert?
Yeah.
No, the ones with the black. Did I give you anyone with the that's in here. We can open it.
Oh,
right?
please, yes.
So there's a metal insert. There's a metal one that has the black. That is what you use to just start it.
Test.
Yes. So once you are taking the impression, you're going to pick up.
You can use pickups from the instruments.
Okay.
There should be a pickups.
No. I said once you where's the denture?
It's in
Right.
your hand.
Okay, so let's see. Let's take it out for me.
I can give you more for that.
So once you have your implants in and your locator, the gold one I gave you, so you have to measure the width of the gingiva to determine the height of whatever locator you're going to need.
No.
It's not going
There's also pickups here. You can
Okay.
use the Explorer. That might be a nice little something to grab.
to. So let's get to another one.
Okay, another
The one with
Oh.
the metal casing
from
from
a different
anybody.
student. You should have 6 of them, Dr.
Okay,
Miller.
sure.
They're very much of a pleasure to have a real live prosthodontist. Because this is his.
You notice this clips in. Let me start with you here. So you can actually pick it out. So this is when you're trying to pick up. So the patient has a denture, right? You've placed the implants. So the patient has a denture, has nothing inside, just like a regular denture. So you put in the metal casing in the little thing I gave you right there. What you have in your left hand, yes. So there's one with a metal casing. Where's
Take
that?
all the little pieces out, Dr. Isaac. You
Where's
see black, pink,
Okay.
blue.
So this is a healing
That's just a metal casing.
to cover it.
Yeah. So you have this one first. So once you finish placing the implant, you put the locator abutment.
Okay,
So on the locator abutments, you put the black metal casing in there. Okay. You put it inside the patient's mouth.
right.
Then you pick it up. So you put some acrylic in here. And once you put some acrylic inside the
There you go.
patient's
Now you found the
denture.
pieces.
Okay, let me have that. Sorry.
No problem.
So you put some acrylic in here. You would have kind of determined you put maybe what's it called Regisil. What do you guys use? Regisil or what do you use? Blue
Blue
mousse.
Blue mousse.
So you put the blue mousse inside here, inside the tray, okay? And you now put the blue mousse over this. So it kind of tells you exactly where the hole.
A bite registration
Yes,
materials.
yes. So you put that, once it's set, you can now tell exactly where this will be. So you use your handpiece and make a hole there, okay?
Yeah,
Then you put some acrylic in here and you place it over this.
okay,
Then conversion. So this metal piece is going to get stuck to this. Such that when the patient puts it in, it clicks in and you're done.
A good snap.
Snaps in and so it's removable as against a fixed prosthesis.
There's a fixed one in the model too.
So you try and take this one comes off. So you can pop it off.
That would be fixed.
So this is a removable one too. This is exactly what you should do for your first patient. So you are charging for the implants, you're charging for the denture, and you're charging for just putting the inserts. Okay, this one uses a ring. It's a different type of insert compared to the one we give you, but it snaps in, and the patient can chew, can eat, and can live life.
I strongly suggest that you do have models because you hand it to the little lady that's 78 who's been wearing a denture that falls in and out, and you say, wouldn't you like one that fits like this? And she cannot even take that off. And then she goes, absolutely, how much does that cost? And then put into a home.
And oftentimes, I'm unlimited income, I can't afford it.
Well, you can eat tomorrow and you'll feel much better if you have some anchorage. Okay.
So I want to understand is that, okay, let me see.
So you place the implants, 2 implants.
Yes, and then this one will go onto the implant, this metal part. You
That's
said-
the locator abutment.
Yes, so this will go in,
Yes,
and then you fit these ones, what you gave us.
yes, over it.
Over it,
Like on the cast.
okay. Okay, so like this,
Yes.
and then you were saying that you use some impression material.
Then you pick it up. So you're trying to pick up this
Where the
this
holes
metal
are.
piece is supposed to be inside your
denture.
tray, the denture.
Okay. Yeah,
So if you
then
put-
this will get stuck to the.
Then to know exactly, let me have to know exactly where this is the where your denture is going to where you need to put where you need to make a hole here that fits corresponds to this place. So you just need some kind of putty, something, put some putty in here.
That can easily come.
Yes. So it lines up so you know exactly where to drill. Because you need to make a little hole here to pick up this head. I mean, there's nothing like doing it. If you do it, you're more likely
Like
to.
this.
But I'm sure we would
This was a.
I'll send you a video of it.
So you put
But
acrylic-
subsequently, I think it's something we can do as well. We have a
You
denture
put some
and pick it up.
put it in another.
Yes, pick up impression. If you put acrylic in here,
And it doesn't stick to the.
so inside your,
Put some run-
let's check inside what you have. Inside those tray, there's a white,
And then it picks up.
there's a white spacer.
So it's one of
So
the
this was.
One of the pieces is a white
So
spacer.
then this marks
It's
into
inside.
here exactly where these are.
I see a blue.
It's right. Punch holes. Well, if you're not gonna, like this.
So the white spacer
goes
goes over it.
Uh-huh,
Okay, so
so,
'cause you don't want
but if you don't want.
the material to flow and get stuck on it. So you put a spacer on top of that.
Snap it in, like on the head of that one. Yes.
So on top of the,
Mhm.
okay, so if you notice, there's a white spacer
Yeah.
inside your
Okay, that's to protect the.
material from flowing down and getting stuck
There we
underneath.
go.
Yes, so you put a
Okay.
spacer to prevent that. Then on top of that, you now put this. Can you put this on top for me?
Interesting.
And you push it in,
Instead of Vaseline and all of that.
Yeah.
That's the.
push it in, and it snaps.
Okay.
That's it. So once you do that, you now pick it up, and that metal portion becomes that's the way we call it, sorry. It becomes the female portion. So it's a male and a female. That is the way it is sold. The female portion becomes inside the
So it gets picked up into the acrylic,
yes. So
the
once it's
denture.
inside, that's right. You just put some acrylic here, put some acrylic there, you sit it in, and you make sure that the occlusion is right. So you want to make
Right.
sure that it's touching and it's sitting properly. So you have to make a hole inside to make sure it sits without any interference. Then it picks up that head, patient is good to go. I do this every day, like literal every day, because people coming, we have placed the implants. I'm sure when I get to work tomorrow, we're going to be doing this every day. Somebody's going to come in. Okay, I need to change my inserts. We change. So the inserts have pink, blue, and clear. Blue is the lightest. The medium is pink, and the strongest is clear. So you want to change it. You want the patient to be able to take out the denture without any stress. So I usually go pink, or I start with blue if they are finding it hard. Black is just the one for basic. So that's not so. It's
Okay.
just very easy to come off.
So this one isn't holding on this side.
So because there's not much space, I think it's just a little deep.
Okay.
Yeah, that's why. So if you have, and if you're, so where's the implant that you place?
They placed mandibular implants.
Okay, so for dentures, so for individuals who need an implant retained denture, this is what you do. So you place your implants. We're going to put a locator abutment. So some dentures require implants to hold them, especially if they've lost posterior support. So I can still place 2 implants and still keep their denture They are removable denture. Okay, so um, you're going to place your locator. There's a prosthetic kit for tightening this, but we're going to use our hand for right now.
Can you use this screwdriver?
No, there's a particular driver that picks this one up. I don't think.
Is it shaped like a triangle?
Yes, but I think for this one, there's a particular one that goes. But this is from BioHorizon, right? Is it in there? That's it. So you probably the locator you choose depends on the thickness of the gingiva.
Right.
You want it to be, equal, just a little bit above the gingiva. If the gingiva is 3 millimeters, you want to use a 4 millimeters, so you can have a little bit. So this one is a little bit high because there's no gingiva right here, so it looks a little high. So if this individual has a removable denture, this can click onto the denture if we do this same process. So you can pick it up and your denture will fit on that. So that way the person's denture doesn't move back and forth. So trying to offer your patient implant is always a good idea, whether they have dentures or they have just one missing tooth, front teeth or anything. Okay. I think that's let me show you. So this is what we're going to do today. We're going to this is the patient's, like what you just did, place an implant there, put a temporary cylinder, and we're going to put some material. You can use acrylic. Some people know how to, some dentists like using their hands, right? So some people just know how to do things by themselves. And as a prosthodontist, that's what we do all day. So like some things like, there's no going to the lab. We're doing this and we're going home. We're getting this guy a tooth. This is the temporary tooth. Temporary. And the patient goes home and she's like, whoa.
And you put that on this.
Yes. You shape it like a tooth.
And the composite, you etch this.
No need to etch. You just because of the serrations in there, it just sticks in there. And it's going to be screw retained. Okay. So the access is on the lingual. So you can, when you take it out, it comes out with acrylic and the abutment together. Okay. For the one we're just talking about, for a denture. So you just pick it up and the patient can go in with just a little lag here. Okay, so do you have any locators with you? You can put it back in here. If you have the open, which one is that? Okay. Healing cap. Okay, this is does he have the okay, how's it in there? Cool.
Oh, there's your picture of those little white things.
Yes. So this is what you do. You put this in the patient's mouth and you put the metal, you see the cap on there? You put this just to prevent acrylic from going down there. You put this on top and you put some acrylic on the tray and you put it in. Once this cap has a little bit of some lines, so that holds the impression, the acrylic inside the denture. So that once you're going in, it just snaps in and the patient is good to go. People that have it, they love it. They're like, wow, this is really good.
And then last but not least, there is one that's a fixed overdenture.
Yes.
There's even another one. It's like a bar.
Okay.
I think it's pink. Is that removable? Yeah, that one.
So this is still like this is a metal, this is a removable, but it has a bar. So you have implants instead of using a locator.
Why would you use this one versus the other?
Really for the maxilla.
Which is?
So this is
the mandible.
Yeah, sometimes you want so they are better together. So united. So once the implants are together, then it's easier for them to stay. If it's one that's going to be wobbling, this is a Hayden's bar. So it fits into like a receiver inside here. So want to put it, and the fact that the implants are joined by the bar creates more retention.
Does it also help with your AP spread?
Sort of. So where you put the implant is where, so you can't really, it doesn't really, it's just that they share the force. Since you have a bar, then they share the force of the occlusion. But if spread is more about where the implant was placed. So you want it down here, but right there, you notice they are all close together in front. So, but it just makes it fit better. Yeah.
But also, I wanted to ask, in terms of the number that you use, you were using the example of the two.
Yes.
Is
For
it
the
like-
mandible,
is the meaning? Okay.
mandible, 2 implant over denture is standard of care. For the maxillar, because the bone density is different, it's softer up there. And so four implants on the top to do a removable is the ideal.
Four,
We do, yeah,
four
four.
is the minimum for the top, but you can place as many as 6.
Mhm.
And you don't want to overdo it. You see these pictures of people who have 12 implants on top, but what are you all doing?
A friend of mine was referred somewhere, and I have to show you the treatment plan. So I was actually in on the surgery, and he sent me his treatment plan. And I showed it to the periodontist. He was like, "What? Like this is like."
With the filters in place, will you still, with the white on top of it, will you still, before you apply that acrylic, you will have to put a separating medium or something?
No. So once you put the white weight is seated on the patient, so you just put some acrylic. So you make a little hole here, make a little hole here, based on where the place is going to be. Then you put some acrylic in there, then you sit it on the patient, then it's going to stick to it.
Okay.
So you'll be able to pick up that female portion. Subsequently, the patient can. So you got to smooth it, make sure you pull it out, any excess that on the edges.
Is it before it's set?
Yeah. After it's set, you can still like clean it up. Once it's set, it's gonna be hard.
Yeah.
You need it to be set before you take it out because the cap is gonna come off. You won't be able to pick it up properly. So that's the So it's either you're doing a single implant or you're doing a 2 implant, 3 units implant. So you put 2 implants replacing 3, you're putting 3 teeth on the implant. So you have 2 implants, single implant, or you do multiple implants.
Yeah, this is only extraction.
So for the multiple implants, you would see. Let me see. You have yours. I put the temporary cylinder. I think this one.
And that's just extracting the teeth that are present. Yeah, that makes sense. That's a big part.
Yeah.
So now that you took all these teeth out, it's gonna do 1, 2, 3, 4, 5, 13, 14, 19. So this is just the maxilla. So he did 3, 4, 5. That's the 3 premolar areas and a molar. He did 2 molars, 3 molar. So that's normal on top. Okay. And on the bottom, he has 19, 20, 29, and 30. That's 4. That's normal. And this is second stage.
Right.
This reasonable. Really? That's normal. That's
So for this patient, we had 6 implants on the top.
That's 6 implants on the top. That was 3, 4, 5, 12, 13, 14. That's right.
For this patient, we did use I used the surgical guide and I placed the implant using tissue punch. So we just punched it. So when we're going to open, I put the guide back to show me where we punched it again. Okay. Place the impression coping, right?
Okay, good. So Dr. Honorable is showing you
Yes.
6 implants. 1, 2, 3, 4, 5, 6. Yep.
I mean, ideally, I should come. These days I'm trying to learn. I'm going for more training. I want to start placing pterygoid implants.
Zygos. Are you ready for zygos?
Those zygos, but pterygoid. So that way, it's more, but this usually works. So the patient comes in, I join it together. These are in the lab. Then I make this out of acrylic. It's good to have the implants away from the facial because you don't want the access to be on the facial. Because if you need to take it out, then you have to find the access on the facial, and that destroys the whole thing. So patient comes in, we try it in. You want to make sure smile line is low. But if you are seeing this when the patient smiles, that means the patient isn't a good candidate for this. If not, you have to put some fixed portion. if the patient smiles and has a high smile line, you should be thinking of an overdenture. That's the way you can tell this is not a good candidate for whatever, you know. So the smile line is important, putting the 6 in there, then trying it in, the patient goes away with it, then comes back, so you try the occlusion. It's just like making a denture. You see this same principle. So you have to do, so before we got here, we make a wax ring, right? After this stage, we make a wax ring that has holes so that we can tell what the bite should be, just like making a denture. So you need to know where the 2 central incisors are going to be, just like a denture. If you start with that, then you can make something like this. Today, they scan it. Oh, I like scanning this. You scan this stuff and they design it with ExoCAD. With ExoCAD, you can do all these. Yeah, most labs have it. And they can print, you can print, this is all printed, you know, and by the time they print it out, you put it in.
But this is given that you don't need osseous reduction.
Yes, you would have determined that all the reduction would have been done, you know, because you have to make that determination first. So you
I
have
think you know that because the person started with an edentulous space, they probably already had dentures
Yes.
in.
Okay.
So there's
That they
no
don't like.
osseo reduction in an edentulous space. They're already wearing dentures that fit appropriate. There's enough space for the restorative component.
Okay.
You have your impression tree, impression close or open, green one.
Show us what it looks like again.
Green. Okay, I have it here. Okay, this is the healing
I
apartment.
don't see the little green, but is it or in between here? Or did you squeeze?
So some people come in telling you what.
No, I don't think he has you yet. Do you have all 6, Dr. Honorable?
So patient comes in and she said, I want an implant. She said, I've done my research. I want an implant. I don't want any other thing. And you look at it and you say, okay. So this is just like putting everything together. So you have to check the medical history, okay? Hypertension, migraine. So there's no contraindication. So this is how you start. Can you have an implant? Is that an option? Is this something you can do? Are you going to send a patient to a periodontist? You don't want to deal with placing an implant. But I think you want to, because it pays a lot. That's what I do. At work, I make more money than everybody in the office because I place implants. You get paid that same day. We're not putting a crown. Once I place an implant, 1,500 is coming right there. I do like 12 a day. 1, 2, 3, 4.
Let me tell you why I started wanting to place implants. So I sensed my office, the ceiling was about to collapse. And I sent my patient to a guy up the street to go do implants. And then I went to the guy and I was like, look, my office is about to collapse. And I need room in your office for about a day or 2 a week. And he goes, yeah, I'll do it. And then he was like, but let me get back to you. And he never called me back. Right. So I went to go take this class. And then this guy was like, do you have any cases? I said, but I have a case, but I've sent it away. He goes, call the guy. If he hasn't done it, then bring him in. And that's how. And so, yeah, and that's how I did it. He was like, we'll split it. So the guy went in, he paid $25,000. He came back the following day, paid $25,000.
That's right.
The day of the surgery, he wrote me a check for half minus the. And so I told the guy, he's a perio patient, definitely. I did the bottom. He said, I can't afford it. And I just want, to keep my teeth maybe in the next 5 years. We hadn't even finished the surgery. He was like, Dr. O said the bottom. And I was like, you're periodontist. And I walked outside, high-five him. So we haven't even, so that's the next stage. We were high-fiving.
Just don't make sure that he doesn't hit the clap of the hand in the hallway. That's all.
But outside, it was like, 3 months. So we'll come back in 3 months. It's like, he came to my office. I gave him an electric toothbrush. I was like, you can't afford perio.
So you're looking at it, you're planning, looking at the gingiva, the papilla. You just have to take a look at everything. So you need to do your clinical exam. You've done history. You need to do your clinical exam. You need to take an impression and see, can you put a tooth there conveniently? So once you do that, take a radiograph and see what you have left. And if obviously you have to do a CBCT. I think it is necessary. Some people think, okay, are you going to restore this tooth? I think we could put the posts and crown it. I try not to do well. These days I don't do that stuff anymore because I just don't want to. I just take it out. If I cannot put an immediate implant in there, this is a perfect place for an immediate implant if you have enough bone. If the buccal bone is still intact, why shouldn't you place an immediate implant? You have to go like just that. Just it. You have to go a little bit palatal because that's where the bone is. They're trying to stay away from. That's a perfect example of that. You're trying to stay away from the buccal bone. You want at least 2 millimeters of bone on the buccal. You don't want to compromise that. And one way to ascertain that, when you look at it, so if you are trying to not to do it with, you see the problem here, you think everything is okay if you look at it like this. I'm thinking I'm just going to go, but if you do a CBCT like we're going to see next, you'll see that, whoa, not a good idea. With a CBCT, you can see the tooth is just, the buccal bone is less than 1 millimeter. By the time you take that tooth out, no matter how careful you are, there's going to be some bone loss. You're going to lose some of that plate. And you're trying to place an implant, you're trying to come here and you're trying to still keep the angulation such that the access is on the cingulum. It's going to be really hard. So for this case, with your 3D planning, you can see things in 3 dimensions. Good way to start. So by the time you take this out, you have enough height, right? You have enough width, but there's no buccal bone. So that means we need to what? Socket preservation. We need to graft this place. Patient says she doesn't want to bridge. So we graft it and we go from there. So every case has to be planned in such a way before you execute. So you placing the implant and restoring is kind of the easy part. The main part for you to see, can I successfully place my implant without?
So you wait
Yes.
after the bone graft, then you wait.
You wait and go back in. It takes some more time, or
Okay.
or some folks can go in, but
Yes.
some go in and graft after the implant is at the same time. You can actually go in. There will be a definite, dehiscence of that bone, but you can still graft it and close it up, and you should be fine. But you have to be like really comfortable with that. With you should be comfortable raising a flap. You have to like really raise it so you can see where the implant. We did one in Cancun. It was same case like this. When I looked at the X-ray, I said that there is radiolucence. Radiolucence, it means some of the bone is no longer there. If you can see to the X-ray, by the time we raise the flap, I was thinking we were going to do it flapless, but we raised the flap and there was a fenestration in the bone. It was the infection had come out, so we had to clean out, we placed the implants. We went palatally. You see, there's no bone there, so you have to put some bone and come back.
A good way to test to see if there's bone there, because sometimes your CT scan will say no, but if you grab an Explorer and run it into the buccal plate, you'll see that there may be more bone apical. By the time you get to the crest, your Explorer will be touching the gingiva, and you can see where the defect is.
Yes. So you have to like take your time and be very comfortable with the anatomy. One of the other things that we need to look at is just the surgical anatomy in terms of what to look for. Maybe before we start in the afternoon, what time is it?
It's 12.
Okay, so we'll come back and we'll talk about it. But I'll just show you one last slide here. This is hopefully you can. Implant was placed, planning was made, and this is where we are. Implant was placed. If you notice, like I said, the implant should be within bone, subcrestal. It was 1 millimeter. I just flush or just a little bit so because you're expecting some bone loss. So it's better for you to go a little bit in, and so the emergence, the crown can emerge properly. If it's not deep enough, then your crown is just going to shoot off with. But if you notice, by the time we finished, even though we had grafted, there's a little bit of some fairness, you are seeing some gray. You shouldn't see gray. Like you place your implant, I can't see gray, right? It's within bone. You want that 2 millimeters around. Once you do that, you just, you can just, but if you don't, if you see this, you need to either scratch your head, just find a sign for your assistant to get you some bone. Or you can take some bone from here. If you have enough, if you reflected enough, you can actually take a little bit of some bone here. But this is not very safe because it's very close and there's not much. If you have a longer space, so you have to like put some. So we have to put a cover screw. So ideally, you would have put a healing abutment into one stage. But since it's two stage means you're going to come back there. So you put a cover screw. A cover screw has no height. That's the difference between a cover screw and a healing abutment. Healing abutment has height 1, 2, 3, 4, 5. But a cover screw is like a nails, flat. It has no height. It covers so you can come back. Then you put some bone there. It's mixed with blood. This is the best. The best.
You can cover the cover screw with bone?
Oh, you can, but you can go there. Once you are trying to open it, you can just reduce it a little bit. It's better to have bone all around rather than leave this place. You're going to have some bone loss. And you can actually use this something called platform switch. Platform switch means you're using an abutment which is smaller than this so that it goes in and comes out that way. So you can actually do that. He's going to talk about that. The essence of making it looks easy, right? Using this thing, it's not as easy. You have to get used to the membrane because the membrane doesn't listen. If it's too wet, it's just going to go. It has to be just damp enough for you to be able to control it. And you want to make sure what's the essence of putting a membrane? To keep it there because you don't want to get into the tissue. You want to keep bone there and it's resorbable. You can also do non-resorbable. That means periodontists like doing that. I don't do that. Go back there and start opening up. No. I don't have patience for that. So this is for this next slide. I think it's time to take a break. You guys have.
If I could, I just want to finish drilling this one.
Yes, please.
Just finish, and then I will put on the temporization attachment. So the next stop is I drilled and I showed, let's see, I checked it out with my paralleling pin. I showed everybody my appropriate angulation, right? We are thinking that the cingulum is where the screw should come out, not in the incisal edge, but the cingulum, okay? And I mentioned that for the maxilla tipped up sniffing position. So I'm going to take my paralleling pin out and I'm going to find my driver for the handpiece. And this one happens to be an implant that was just in a different spot. So I don't have the same little container. I'll put the implant in. If you would, Doc, can you put on the implant setting? Okay. And now I'm coming in, same angulation, orienting my drill appropriate direction, and I'm going to push my pedal in until it goes all the way down. It's probably going to stop just short as it has for all of you, and then I will ratchet it down to the final millimeters so that it is subcrestal. Let's see, it didn't stop yet.
Oh, it's moving.
Yeah, it's moving. Maybe I drilled it just right. All right. And then I'll take my ratchet, right? And I'm looking for my arrow, right? I'm looking for arrow down attachment. Now, let's say for lack of a better circumstance, this is a tight space here. You all have been working on edentulous spaces, having plenty of room. Let's say I need a little more length to my ratchet. So I'm gonna, because I don't want my ratchet to touch my teeth. So I'll have an attachment, which is an extender, and now my ratchet. And now I certainly will not be touching my teeth, okay? And same thing as I'm teaching you, I'm holding on to this and I put my finger here and I'm gonna ratchet it all the way down until I get to it being crestal, just at the crest. I used to say I like to sink them, so just at the crest. And then again, take my attachment off. There is also an extender in the event that you are utilizing your handpiece. If you need an extender for your handpiece, extender is going to be top corner. You put the extender in the handpiece, okay, and then you put your driver into your extender. This is helpful for like premolar spots. Again, don't want to damage any adjacent teeth. So that was just to show the extender. I'll put these things back. Every time I take something out, like Dr. Honorable says, I put everything back. And then last but not least, I could put my, I could put my cover screw, but Dr. Honorable, can you give me the temporization attachment? So could put the cover screw and then have the patient wear their flipper. It's flush, right?
Mhm.
Or I could put my attachment that we'll have Julio use to this afternoon for making the temporary.
So when you go to the lab,
Thank you.
when you go to the lab on, just really watch out because they have, it's a very beautiful lab. Kind of, so if you have cases, everything that you need, clear communication with the lab is essential.
Two pieces, the screwdriver, the screw, the green and gold. The screwdriver, you're gonna add the screwdriver to the green and gold, and then screw this down in here. Now I'm gonna pass this around. Julio this afternoon will make this into a crown.
So what you have there is a prefab abutment. So for most of your cases, I would advise for you to use custom abutment. A prefab abutment, just because of the way it's attached, is sometimes it breaks because prefab is just not, it's not casted. So usually I would, once you take your impression, ask the lab to get you a custom abutment. So a custom abutment fits for you, is for your patient, was made for your patient. So this is a custom abutment, and you can determine how you want. You can have it in titanium, or you can have it in zirconia. I decided to use zirconia because this is front teeth, and if it's dark, it's very hard to mask it and keep it the right color. I tried very hard to match this. This patient was, I was like, can I do, maybe I should do some more work. Because I'm looking at it, I know I can see the things that I don't like. Patient is like, I love it. Like, no, she's like, see, if you, as a prosthodontist, I'm thinking zenith, right? The gingival, it should be right here.
Yeah.
It should be equal. The zenith of the centrals is the same zenith as the canine. Just like in making a denture. So I know all that.
Or you could reduce number 8, sorry.
This, how do you reduce it?
Yeah, how you gonna do that?
You have to graft it. You have to do more surgery, right? You have to do something. By the time we're done, the lady's like, I don't want more surgery. I just need it to do.
Leave well enough alone.
She was so happy, and she was like, wow. Even the color, it's not easy to match fronted because they all have different colors. All our teeth have different colors. The canine is a little yellow, the laterals are a little but patient was happy, and she's like, I'm not coming back to this place. I've had enough. But a couple of appointments, and one of my best patients, and I was so it makes you become friends. These guys come to your clinic a couple of times. 1 month, after 3 months, they come back. You guys will know many things about your patient. Patient will know. She had a number where she could text. Not my, so I have like a Google where my patients could reach out to me on Google. I can receive messages, and she's happy when she paid. Once you place the implant, you are paying $2,000 that same day. In 30 minutes, tomorrow, I have 4 implants to place when I get home. And that is 4 times $2,000. So the manager is all like, are you coming in tomorrow? Because they are thinking about it. So you arrive there. See, I've already planned it. I'm thinking about, all the parts. So I get there, boom, boom, boom. Within how many minutes? In 30 minutes, we're done. You are paid. just because I could have, there are some prosthodontists who don't like placing implants. They just want to restore. I'm like, no, I can. If I'm thinking of helping people, then I want to do something that can make a change immediately, and it adds to your skills. You're trying to add treatment options instead of your periodontist is going to collect your money all day long if you keep referring your cases out. And it's something, I mean, you just place an implant. Just in the mouth is going to be blood, tongue, saliva. That's the difference. And numbing the patient, you have to be sure that the patient is numb because you don't want them feeling pain. You're drilling. You don't want their no. I give a lot of I numb the patient up. They all live their life.
So what do you give in this situation?
Septicane.
So, yeah.
Maybe two carpal septicane.
Maybe.
Inferior alveolar nerve or Galbraith's?
People are blocked. And it's funny that you asked that because we have another lecturer who said that he just does infiltration. And then we did the procedure and the patient was uncomfortable. And I was thinking, well, if we had done a block to start with, why do we need to do infiltration? So to everyone's comfort, everyone's hand skills, I don't want to stop and start. I want to have them numb and we're done. That's how I talk.
So septicane block, inferior alveolar block,
Yes.
Gates, and
Yes.
infiltrate.
Yeah, I'm talking like 30, 19,
Mhm.
31, 18, 22, 27. That's what I would do. Absolutely.
All right. So we'll
You
continue
want
from
to
there.
take a break?
We could if you no, we
Break
can
if
continue.
you have more? Okay, go.
Oh yeah, we have a lot more.
Are you on the screen and like who's that up top?
Yeah. So this is
How are
the only
you?
way I could get this thing to work is I have to connect it to Zoom. Anybody can watch from anywhere right
Okay,
now.
this is a so it's moving along with you talking
Yes.
from another presentation.
No, it's right here. It's on the computer here, but I had to connect it to YouTube to be able to. I think the cord.
This course not good. So should I ask them for HME
Yeah,
for tomorrow?
Oh, you need that. So that way it's real time. You need to just be conversant with what kind of bone are you going to? Are you using the D1 bone, which is dense cortical bone? Or are you in D2, which is coarse trabecular bone surrounded by there's a thick portion. So when you drill initially, it's going to be hard. Then when you keep doing boom, it's just going to drop. You'll feel your hand go down like, oh no. And so you want to control it so you don't go too far because there are holes. It means the trabecular portion means it's hollow, soft. Then here it's pretty soft. Here is like it just goes in. So you want to know bone density. And you need to know structures. The IN, where's the nerve? So you want to be sure, you want to be like 3 to 4 millimeters away from the nerve. Because when you are drilling, you could hurt the nerve. You could hurt the nerve, not necessarily get into the nerve, but you could create heat close to the nerve, and that heat causes some damage. Or you could create so close that it pressure can cause some damage to the nerve. So you want to try to avoid that. So knowing the structures that are there, it's important. First of all, like I said, when she comes in tomorrow with the CBCT 3D, there's a 3DCT machine in this hall here. We're going to go over there tomorrow. Then she's going to come in with the software. Once you put the cursor on the software, you can tell what the bone density is. So with most of those 3D planning software, you can paint the nerve so that you know exactly where the nerve is. So when you plan your implant, I usually like being 3 to 4 millimeters away from the nerve. So that way you are rest assured. It goes back in trying to block and it's like basic anatomy that we learned before we start in terms of where is the mental nerve? So you need to know where the mental nerve is. Because if you're just going blindly without, you're probably going to hit it, especially if you're right there, right there. So you already know, and if you are reflecting all the way, I walked the oral surgeon's I've watched like a couple oral surgeons, do surgery, and I'm like, wow, these guys are pretty comfortable with it. This guy was going and going and going. I'm like, he's like, I'm going to show you the mental nerve, and you can see the difference. You got to be able to tell the color between the color and where he knows where it's going to, and you can tell so he can avoid it. I was like, oh, this, sinus is something like this guy was just ripping the sinus off. They were doing it, the sinus is not as protected as you think, it survives a lot. So you need to know some basic anatomy where you're trying to place an implant there, right? You should know that there is a nerve running down there. You should have that, and you should know that it comes out right here. And sometimes there's an anterior loop. So you need to know where that is inside the bone. So you don't want to, your patient is numb. So they're not going to feel the damage that you would have done by the time you're done. So if you don't know, you keep going and going and going, you're going to hit that nerve. And by the time the patient is done, they're like, I don't feel any pain afterwards. So what are we going to do? So that's a bigger problem. So you want to keep your anatomy in mind.
And Dr. Roby is now good time to take a break.
Sure.
Okay. Okay, folks, here's what's happening. First part is, I think it's time for everyone to get a little food. I'm gonna lay out the vegetables. There's turkey and there's ham and there's biscuits that you can make a sandwich with. There's also a cheese platter, which is absolutely delicious. So try all the different cheeses. Briefly, Dr. Anarobi and I are going to run to a quick store and buy this cord that we need. And once you finish eating, I am going to get you into the clinic. This is all on 4 season. This for 3rd season. So that means that most of the cases today are going to be the removal of wisdom teeth. But that's just today. Tomorrow, different kinds of cases, different kinds of things. I want you to be especially aware of how Dr. Bhatti is placing the IV, because eventually you're going to be placing IVs. I want you to be especially aware of how he's using the bite block to keep the mouth open. These are all going to be sedation cases. I'm going to go over the monitors with you and the medications that are utilized, because we're also teaching you anesthesia. Mm-hmm. And then you're going to see how he's going to take wisdom teeth out in no more than 25 minutes, top and bottom, left and right. And then he's going to close the cases. So you're going to see the efficiency of suturing. And then by then we'll come back, we'll do the impression of the case. And then at 4 o'clock, we will do a chair side temporization. Okay, everybody all right? Still with me? Yeah. Awake, how do you feel? Good. You're good? Okay. Any questions? Then I'll set up the kitchen and get ready for lunch.
Very good. So I wanted to find out the one that you are using, the close technique of the impression. So when you put the impression coping,
yes,
that one, do you screw it in?
Yes, you have to screw it in.
Screw it in.
Yes.
Okay, so when you bring the impression, that means you have to unscrew and then manually
push it in. Yes.
But when do you alter the position?
No, it's already set.
Okay.
So it fits in a certain way.
Okay.
So you're just going to click push in. It in. Okay. You just push it in and it snaps in.
Okay.
Just like where's that tray? We had a tray here. So once you connect so you probably want to connect the analog here first. Then you just push it into the space. So it just goes in. So it has 3, it's kind of tri-lobe. So it goes in. Once it's soft, this has been there for a long time. So once it's set, it just goes in. But for the open tray, you have to make a hole here.
Mm.
So you have to make a hole
You
quickly.
have to loosen
Loosen it.
on
That one, you have to loosen it first. If not, you can't take this
Yeah.
out. You'll be wondering.
Mm.
I'll get that out. Yep. So while we're waiting, you can actually you need to try to avoid trauma to the nerve. And trauma could be from your needle going directly. You're trying to place it. So, you know, some of the patients like, oh, they jump when you're trying to place the block. Because the block, where it comes out, or where it comes out is just at the level of your the occlusal plane,
Right.
or slightly above. So there's variations. Most people it's at the level of the occlusal plane. So if you go a little higher,
So
then,
that electric shock,
yes.
I hear is the lingual nerve, right?
Mhm, mhm. So trying to avoid that. So you just want to make sure that you're not going and causing some endoneural edema, because you need it, or and you push it in, you're going to cause some swelling, inflammation. You're trying to avoid that. The other one that you're trying to avoid is partial or full intrusion into the mandibular canal. That can happen, especially for someone who has a lot of resorption. Somebody who has the bone resorbed, then the nerve is going to be closer to the surface. So you won't have enough height. So that's why you need CBCT to be sure. Because for a regular person, it's right there. But once you've lost some bone, then your nerve is going to be very close to the surface. So you're trying to prevent. So having a CBCT is key, so that you can at least have some measurement of where exactly that is. Full intrusion, you can. So you're trying to avoid that. You don't want, and using a guide is truly. Did we talk about a guide earlier? We don't want any injuries. So first of all is to find your patient and be able to be comfortable. Find a molar tooth, number 6. Try not to do number 7 or number 2. Because the closer you are to the back, the closer you are to the nerve. It's like a nutcracker.
Hold on, you're saying number 6, that's the second molar?
The first one, yes. Number 7. Number 7 is I'm using
Yeah,
number 2 is
Right.
your second molar.
right, 2 or 15.
Yeah, you're trying to stay away from 2 or 15 because it's closer to your sinus,
Mhm.
and on the bottom is closer to the nerve. So if you just keep yourself from 6, your first molars and premolars, and stay within that zone. So that way, you're trying to avoid, and you have to really measure. You have to keep looking at it. You have to take a look at the drill and say, okay, where are we? I do it all the time. I've done this several times over. I never get. My sister's like, but you already know. No. I look at it again. It's like habits. That's the only way you don't get any injuries. You have to let it loose. Any of this can happen on your drilling. You don't want, the partial implant intrusion into the mandibular canal. That can happen. You don't want that. Patient is numb. Nobody feels anything in your drilling. You just drill it away. You have to make sure once you put your first drill, take an impression, like an X-ray to be sure where you are.
And the symptoms, would that be right away, or would that be how much?
After like 2 days, the patient I don't feel it. And this is no. All you do, you tell them, don't worry, it's gonna go away after some time. So, but 3 to 4 millimeters. Stop drilling. You have to plan in such a way that you're drilling less than. Should be good.
Oh, you already have. Don't forget this paper. Okay, so all your parts and pieces. I don't worry.
Spend.
Let's give them a little bit.
Okay. Okay, ready?
Oh, okay.
Okay, folks, anyone hungry? Yeah, okay, come this way, please. And I'm just show you. There's cheese, ham, turkey, white cheese, hummus. And then water, put forks in the turkey, one the lighter one turkey, the dark one. Okay, and a little cheese, and then I probably will come back within a few, like, no more than 10 minutes, but our next step is to watch surgery, kind of get our minds a little change of pace, and come back for a touch. Okay. Bon appetit.
USB-C to USB-C. I think that's what it is.
Let me show you. So I always see that it's three pins like this, one up. But it's not.
Oh, no,
as
yeah,
small
I
as
know what
one.
you're talking
Ah,
about,
ah.
yeah. I just have the one that goes to like an iPhone,
Ah,
like this. This wouldn't go into there.
yeah.
No.
But see how small your end is like.
Yeah.
Mhm. I never thought about it that way. like some people say. Hey, sorry, I left you alone. We went out. We're like outside into.
Yeah, I went to
Uh,
get some.
And he was up there too. See, look at that, what is that under there? Under
Yeah,
the-
yeah, I saw it
That
back.
white box,
Yeah.
what is that one?
It's still the same pin.
Oh,
So this can go inside,
Mm.
but here you can connect. It's
you plugged it,
not charging.
Mm.
oh, see, so that one, it's not charging?
It's not charging. I don't know. Maybe because it's not there.
He needs like the middle piece. It seems like those are like the Samsung, that's what it is.
This is in Huawei,
Oh,
but I don't know whether
the iPhone
because this is
charger
an
they're not gonna
iPhone.
work.
You know, it's like very sensitive. This kind of.
Yeah, yeah.
So would yours be considered an Android?
Something like that, yeah.
What do you?
I have an iPhone.
Okay, I got the cord. You guys, well, let me take you to the surgeries, okay, because they're actively happening. I want to introduce you. And I want you to see how.
But I missed you. I should have asked. You know, my phone. I can't charge my phone. I can't charge my laptop.
Okay.
See how my
Yeah,
you
that's a
know my
European.
laptop.
Yeah.
I mean, need something. You don't have
An adapter.
Yes.
We don't have that. I've been to Europe before. I have a hair dryer that I can never use again. I'll give it to you. It comes with that kind of.
Yeah.
I can get you one to mine tomorrow, I'll look for it.
My phone is gone there.
Dash. Yeah.
What kind of phone do you have? Android? You have a
Yes,
charger,
it's
the
Android.
cord?
Yes, I have the cord. I have the cord that I can connect from USB.
Is that your cord in the wall, Doc?
No.
No, that one in the wall, is that for your,
That's for, it was here.
No, I can have.
it was here already.
Yes.
It's okay.
Okay. Okay.
Sorry.
Dr. Isaac, come this way. I'll bring you back.
I'm not gonna use it, let me see. Oh, it's a USB-C to, no, I don't need that part, I just need to use, I'll leave it back here when
Okay,
you're
sure.
done.
Sure.
Just need. This one, need some juice. Is it working?
Cool.
Yep, there we go. I didn't think I would be talking to my cousin all the way here.
Oh, okay.
Okay. I'll leave this here.